Okay.
We are live now, Doctor.
Okay. Good morning, friends. On behalf of the Tamil Nadu Ophthalmic Association, as the president of the TNOA, I would like to welcome you all for this 7th TNOA Connect series. As you all know, we started way back in September 2021 with RAO-GOH, and it was on mucormycosis. Subsequently, in October, we had with Shankar Nethralaya on pediatric ophthalmology. In November, we had with Agarwal Eye Hospital on IOL fixation techniques and challenging video cases symposium. December, we had on cornea and refractive surgery with the Eye Foundation Coimbatore. And January, we had on cataract and IOLs with Rajan Eye Care. And February last month, we had with MN Eye Hospital on oculoplasty. This month, being the World Glaucoma Week and World Glaucoma Month, we thought we will culminate all the glaucoma celebrations or awareness with this webinar. And it's very appropriate that we have this webinar in the last week of March. And we have done a lot of activities as part of the TNOA. We launched the GAP program, which is the Glaucoma Awareness and Prevention, with the Health Minister of the Government of Tamil Nadu, Mr. Masu, launching it at Rajan Eye Care during the Glaucoma Week. Aravind Eye Hospital, Tirunelveli, under the able leadership of President-elect Dr. Ramakrishnan, doing wonderful work on awareness of glaucoma, rallies. They have conducted programs on the TV, programs in the media, and a lot of the posters and awareness programs are being conducted as part of that. Of course, we had a very, very successful program on glaucoma awareness, which is a rally which was conducted by the Tambaram Ophthalmic Society during the Glaucoma Week. I think it was March 13th, if I remember right. And during the Glaucoma Week, it was a very, very huge success as well, with more than 300 students participating in the rally under the aegis of TNOA. Of course, many other programs have been done in RAO-GOH, Shankar Nethralaya, Aravind Chennai, and other major institutions as well, which have contributed to create awareness on glaucoma and increase the sensitivity about glaucoma among the patients, so that patients come early to the ophthalmologist. I'm very thankful to the entire team for taking care of this Glaucoma Awareness Month, and it's very important that we take each specialty every month and we do it so that it creates awareness under the aegis of the TNOA. I'm also very thankful to our President-elect Dr. Ramakrishnan, who's been spearheading this glaucoma awareness campaign and across Tamil Nadu as well. And this Connect series, we have connected with the major institutions. The main objective of the Connect series is to cover every subspecialty of ophthalmology. And we've been doing that very successfully for the past 6 months. And this Connect series the main aim is to connect, communicate, and consolidate, the 3 C's, wherein, as you all know, all the major institutions in the country are in Tamil Nadu, the gold standard institutions, I would say, which are teaching. And we thought, okay, let us give one chance, one webinar to each of these institutes so that they can have their, expertise from their own faculty as well as the faculty from the rest of the country as well. And today, we have none other than the 4 stalwarts in glaucoma, not only in Tamil Nadu, but the entire country, entire world, I would say. And Dr. Krishna Das, who is the Chief of Glaucoma, Aravind Madurai, Dr. Ramakrishnan, our President-elect, Chief of Glaucoma, and Medical Director of Aravind Tirunelveli, and Dr. N.R. Rangaraj, who runs a very successful practice, the Premier Eye Care Center, and also is attached to the SMF as well. And he is also a very well-known glaucoma specialist. And of course, our own Satyan, who is a member of the management committee, who has been spearheading this completely and coordinating this glaucoma webinar, along with Dr. Krishna Das and Dr. Ramakrishnan, with Aravind Eye Hospital, Madurai. So this glaucoma symposium, we have got fantastic speakers lined up as well. The glaucoma symposium is mainly to create more knowledge among not only the residents and the postgraduate, but also the practicing ophthalmologists across the country. And I'm sure this Connect series also will be a huge success as well. Because every Connect series we have been having a huge response on the YouTube and the Facebook of the TNOA, with more than 2,000, 2,500 people logging in, not only at the time, but also later also, they intend to watch. I'm very thankful to the Hoya Surgicals for sponsoring this webinar as well. And of course, the back-end team, the Sai, Krishnan and Manju, and the entire Numerotech team, we have been doing this consistently without any flaw. The theme of the Tamil Nadu Ophthalmic Association this year is Tamil Nadu Smiling and TNOA Shining. And we have been doing that to the true spirit for the past 6 months. Last week, we had a fantastic TNOA mid-year Galata meeting and at Ideal Beach Resort, Mahabalipuram. It was a huge success. And the main objective of the meeting is for people to come, sit back and relax and enjoy. And there are no scientific sessions at all. And we had the privilege of honoring all the past presidents of TNOA with the Pride of TNOA Award, and 2 non-ophthalmologists with the Service Above Self Award, Mr. Lion Harinarayan of Shankar Netralaya and Rotarian S. Vishwanathan of Shankara Pammal. And of course, we recognize the services of the late Appaswamy Sir of Appaswamy Associates, and we gave the Pride of India Award to Appaswamy posthumously. And very nice of Dr. Rangasamy, Aravind, Pravina, and Prasanna, the 2 daughters of Appaswamy, to come over to the function at Ideal Beach and receive the award on his behalf. So the TNOA mid-year meet has been a successful meet. I'm very glad because every it is like a Midas touch this year. Everything we touch in TNOA, I think TNOA has become a brand now. It's one of the top associations in the entire country, shining like that. And we have done a huge number of programs in the past 6 months, and we are continuing that in the next 6 months also. And as I told you in the meeting last week, I am very happy and blessed to be associated with a great team. The president-elect, the vice president, the secretary, of course, Dr. Madhavan, the treasurer, Loganathan, and the entire team of office bearers, the management committee members, and of course, the immediate past president, Thangavelu, and also our advisor, Dr. Siddharthan, and many other people who have been involved in giving me proper advice and so that I can keep the motivation on throughout the year. So with these few words, I hand over the proceedings to Dr. Ramakrishnan, President-elect, to say a few words, and then followed by our secretary, Dr. Madhavan. Dr. Ramakrishnan, sir, over to you.
Respected President and Secretary Dr. Madhavan and Vice President Nirmal and my dear Ravi Shankar and the dear panelist Dr. Krishnadas, Rangaraj and Satyan and dear speakers and delegates. Good morning to all. Really, it's a good day for us, and I have to thank our President Dr. Mohan Rajan for giving us the opportunity to organize a symposium on glaucoma today. As he mentioned, now the Tamil Nadu Ophthalmic Association, under the leadership of President Dr. Mohan Rajan, a lot of innovative ideas in the field of ophthalmology in teaching and training, and so many things like what we mentioned already is going on for the past 6 months. He has not left any stone unturned in these last 6 months. Everything for ophthalmic fraternity, including the doctors and postgraduates, fellows, and also paramedics. In that way, that today the TNOA Connect series, the glaucoma, I'm very, very happy that I actually have to thank Satyan and Krishnadas for formulating the topics and also allotting the speakers across the country and also from different institutions of our state, Tamil Nadu. And as mentioned by our president, the glaucoma is one of the important cause for the irreversible blindness, which we have done this awareness program in the last month all over the world. This program has happened all over the world because since it's a silent disease and also irreversible, to make the awareness among all sectors of the people. is very, very important. Similarly, in that way, we have in our state, all the major hospitals, including government and NGOs, they have conducted numerous activities to promote the awareness among the general public. And also this symposium is also very well planned in such a way that it will be useful for practicing ophthalmologists, not only for them only, it's also useful for the fellows as well as postgraduates in ophthalmology. The topics are also very well chosen, and there are 7 topics in this symposium, and 4 are mainly concentrating on the investigative part of the what is happening in the recent years in the investigation. 4 topics, and later 3 topics are the management, medical and surgical management in glaucoma. And of course, because even though we are conducting so many webinars and conferences and other hands-on training, it's an ongoing, because every day the science is changing, and also the glaucoma field is not exceptional, because when we joined our postgraduate, there are only pilocarpine was there, and later timolol came. But now there are so much of newer pharmacological formulations are there to treat the glaucoma. And of course, the diagnosis also. We started with the shared tonometer and the germ screen, but now they are all outdated. So there's so much of newer things are coming up, and so we have to update our knowledge in glaucoma so that we can give a better care. The quality of life of the patient is very, very important than just controlling mere control of intraocular pressure. That way, I hope this symposium will be a wonderful thing, and also useful for all of us. And I again, once again, thank the president and all the panels and also the speakers of this symposium. Thank you very much, Dr.
Thank you, sir, Dr. R.K. sir, for always a very, very motivating and inspiring talk. And we are looking forward to your guidance in the TNOA in the future as well. And I'll be feeling my duty if we don't mention the support and the contribution by Mahatma Eye Hospital, Trichy. Go Green by Prasanna Venkatesh, Ramesh, and the entire team there. The Go Green for glaucoma, which have been doing successfully for the past so many years. This year also on March 6th, in fact, they are the first ones to start the program. In fact, on March 6th, it was a very huge success. And I saw the photos also. I put the photos also during the TNOA media meet. Thanks, Prasanna, for supporting this, and we're looking forward to a greater contribution from you in the future as well. Over to our dynamic president, Dr. Madhavan. I always call him the unsung hero, the guy who is really so competent and committed. Madhavan.
Thank you, President, sir. Respected President, our President, Dr. Mohan Rajan, President-elect, Dr. R.K. sir, our MC members, the allied panelists, Dr. R.K. sir, Dr. Krishnadas, Dr. Rangaraj sir, and our own Dr. Satyan, who incidentally is the Chairman Scientific Committee for our next TNOA conference at Coimbatore. And the allied speakers, and of course, the members of our association who are tuned in to YouTube and Facebook. Welcome to Glaucoma Connect series in association with Aravind Eye Hospital. A day to connect, communicate, and consolidate our knowledge sharing. So incidentally, the TNOA initiative of Project GAP, Glaucoma Awareness Prevention, Create Awareness, Prevent Blindness, was organized early in this month under the aegis of TNOA, as our president was telling, at Rajan Eye Care, Aravind Eye Hospital, Tirunelveli, Tambram, and of course at Erode, and also Trichy, which had a Go Green cricket initiative for the 4th year in succession. And last week was a memorable mid-year meeting following a managing committee meeting at Chennai. And our president honored the past presidents of TNOA with Pride of TNOA Award for their excellent services to our association for the past so many years. And incidentally, this was the first physical meet after a long time. And members really appreciated the wonderful effort taken by our president, Dr. Mohan Rajan, and Madam Dr. Sujata Mohan as well. Thanks to them, we had a wonderful mid-year meeting last week. So looking forward to today's knowledge sharing on Glaucoma Connect series. And we indeed thank Hoya and Numurotech for their relentless support to our initiatives. And of course, TNOA is indeed shining. Thank you. Thank you for the opportunity.
Thank you, Madhavan. And your presence itself makes a huge difference for all of us because you are so committed. I think we are very passionate about TNOA, and that's what I have learned from you. And I think all the people, I think it's really fantastic. Just being an office bearer is something, but beyond that is something different. Okay. And that's what I think Madhavan is a perfect example of that. Dr. Ravi Shankar, member management committee, my right hand, left hand, center, everything, to say a few words.
Very good morning. Vanakkam, namaskar. Indeed, a pleasure to be here in the Connect series, and once again, a great initiative from the president. And every member of TNOA is looking forward for all these wonderful programs every weekend, and particularly the Connect series. And on behalf of Tamil Nadu Ophthalmic Association, is indeed a pleasure, and a big thanks to Aravind Eye Hospital and the man behind the scene, Dr. Satyan, Management Committee member, TNOA, who has been working relentlessly for the past 2 weeks to have this program happen today in a grand success. Thank you, Dr. Satyan, once again for doing it for TNOA. And over to President to take over the proceedings and to go into the scientific session.
Thanks,
Thank
Ravi.
you so much.
Yeah, thanks, Ravi, for the support you have been giving all of us, especially for me, because you are taking the main, the brunt of my work. And I'm very thankful to you. Over to Dr. Krishnadas and Dr. Satyan for the webinar. And Krishnadas, thanks a lot. Thank you very much, Krishnadas, for being, it's a great honor to have you in this webinar.
No, don't say that. We are very happy to be under your dynamic leadership. You have been, as always, from school days, not surprising, but TNOA has been excessively active this year. And I hope your successor, the great RK, will also continue, and as it will happen with the rest of the leadership that will succeed. I think we should delve right into the scientific sessions, because we are almost 20 minutes past 11 now. Dr. Satyan?
Yeah, I think we have to go on. Thank you, our respected president and other panelists and all the TNOA members. Thank you so much for giving us this opportunity to conduct the Glaucoma Symposium today. We have the young and middle and the eldest, so that they can share their experience. So you can see from the first speaker is going to be Dr. Sweta from Satyan Eye Care. She's a consultant. Sweta, can you just open up your presentation? And she's going to talk to us on the optic disc. So we have, as RK sir was mentioning, we have diagnostics, and also we have the management part. So the session is divided into two groups. So over to Sweta.
Thank you, sir. A warm good morning to all. I would like to thank the organizing committee and Satyan sir, my mentor, and Krishnadas sir for giving me this opportunity to speak on one of the most important topics that we should know, being a practice ophthalmologist, not only glaucoma specialist, even the resident and the practicing ophthalmologist, the decoding the disc. We have to start early so that we can prevent the blindness and preserve the quality of life. So as I said, I'm Dr. Shweta, glaucoma consultant at Satyan Eye Care Hospital. I'll straight away go into the examination of the optic disc in glaucoma. So we have lots of options for seeing the optic disc. So what are the problems with the direct ophthalmoscopy? We have no stereoscopic view and it's a magnified image. Whereas in the indirect ophthalmoscopy, the magnification is so inadequate that we may not be able to outline the cup and the RNFL defect properly. And slit lamp with a 90-day examination is it has an excellent illumination, high magnification, and a good stereoscopic view, as well as we can quantify the cup size along with the using the slit lamp. So you can use different 60D, 78D, and 90D lenses. The important thing when you're using the 90D examination is that you have to record it. So it is given in Becker-Schaffer how we can record the optic disc in glaucoma. You have to divide it with 4 horizontal and 4 vertical lines, and draw the disc accordingly, like what I have shown. The temporal margin is not that well defined. That's why you have to mark it in these lines. So this helps us in when we are coming. Glaucoma is always a progressive disease. So when the patient is coming for the next review, or maybe after 1 or 2 years, when he has a progression like this, we'll be able to get a good idea. But having said this, it's always a subjective thing when we draw. So it is always better to go for a fundus photography in a glaucoma patient. If you do have a fundus camera, make sure that you take a baseline examination, if possible, for all the cases, so that you do not miss any findings of glaucoma. As well as otherwise, you can do at least for the high risk patients, there should be at least one baseline fundus photography examination, and every year you need to see the fundus. So when you look at the fundus, you have to go stepwise. Never go into just directly to the RNFL defect or the cupping. You have to go stepwise, like see the media, see the disc, what is the margin, size, shape. Then comes the color of the NRR. Then is a neuroretinal rim. Then only you have to go to the cup disc ratio and the vascular changes, then the peripapillary area and the RNFL defect. If you follow this, you will never miss anything. So what is the importance of disc size in glaucoma? You know that there can be wide variety of disc sizes in each individual. You can have small disc, medium-sized disc, and a larger disc. So I would like to show one illustration which shows that if you have a large disc and a small disc, the large disc, the neuroretinal rim can actually accommodate lot more axons, lot number of axons than a smaller disc. So it is okay to have a 0.5 or 0.6 cupping in a larger disc, but if you have the same 0.5 cupping in a smaller disc, that is something which we have to be careful about. So this is one of the beautiful photo which you can understand why the large cup in a large disc is okay. So this shows the OCT in which the BMO area, if you can see in the left, it is a 1.6 millimeter square, and the right is a 3.38 millimeter square, just to show you that there are a wide range of optic disc size that can happen. Even in the same individual, you can have inter-eye asymmetry of the size. Next comes the disc shape. You can have a rounded disc or a vertical oval disc or a pear-shaped disc. Here, the pear-shaped disc may confuse you, thinking that you may get an idea of an inferior notch. And even the vertically oval disc may have a vertically oval cup, so that you may think that there is a glaucoma. So you have to actually see the disc shape in each individual. So this patient had, this is a right eye of the patient and the left eye of the patient. You can see that disc shape is so different that you may think the right eye is abnormal, but actually this patient was a normal patient. Next, coming to the disc color. So you have to look at the neuroretinal rim color. So when you have a pallor of the neuroretinal rim, you have to think that there is something else going on other than the glaucoma. Especially you have a bilateral cases in which you have bilateral NRR pallor. You have to think about other toxic optic neuropathy or traumatic optic neuropathy. It can be compressive optic neuropathy. Something other than the glaucoma can be happening. So you have to go ahead and investigate for that. But is it always that you won't get a pallor in glaucoma? It is not like that. If suppose you have a high pressure like 50 or 60, like you have an acute angle closure attack, during the attack the disc may be hyperemic, but once it settles down, later on you can have the pallor setting in. So even glaucoma cases, if they had a high attack of like acute angle closure attack, they can have a pallor of NRR. So you need to keep that also in mind. Normally it is pink in color. So next is the neuroretinal rim. We all know there is something called an Nissen rule, which states that the inferior is thicker than the superior, which is thicker than the nasal, than the temporal. But this is not always true. Not all the patients have the same, they do not obey the Nissen rule. So even if it is the inferior is little thinned out, it can be normal for the patient also. The most important thing in glaucoma diagnosis is having a notching of the neuroretinal rim. Notching is nothing but a focal thinning of the neuroretinal rim. As you can see in the left hand side, there is an inferior notching, and in the right hand side you can have the bipolar notching, the superior and the inferior. So along with the notching you will have the RNFL defect. So only after seeing the NRR go into the cupping. So cupping, the most important thing is how to outline an optic cup. So it is not always white color represents the cup. You have to see the vessels there. If you see this vessel, there is a bending here. This bending represents that is the cup margin. And also look for the color change. Color change in the sense you have the brighter color coming to the darker color of the vessel. That is the area where the cup margin is. Also look for the disappearance of the cup. So this is the most important thing which you have to understand, that you have to outline the optic cup and only then go for the what is the cup disc ratio. Because even in the 90D examination, these vessels are beautifully seen. You can outline the cup very easily. So bending, the disappearance and the color change is the most important. So large cup to disc ratio is an important in glaucoma, and but all large disc with a large cup is not glaucoma. So if you have an asymmetric cupping like this, you have to go ahead and investigate either by OCT or a visual field and look whether there is any change. So progressive cupping is always indicating of glaucoma. So next is the vertical cupping. So vertical cupping means there is a superior and inferior thinning of the neuroretinal vein. Now coming to the disc hemorrhage, if you see the direct 90D examination, you may miss most of the disc hemorrhage, but when you take the fundus photography, you can see that the disc hemorrhages, you can see here there is a absorbing disc hemorrhage, and these are the other splinter hemorrhages. What does disc hemorrhage indicate? It indicates that the disease is still active, and you need to look at more other factors, like there can be some vascular factors playing on. Just go ahead and look for the carotid Dopplers, cardiac, what is the cardiac status, and also we can even keep the target IOP little low. This happens in the NTG patients. So, but disc hemorrhage can happen in Valsalva also. You can have in other diabetic and hypertensive retinopathy. So if the disc hemorrhage, when it is absorbing in about 2 to 3 months time, if it is leaving an RNFL defect, it means that it is corresponding to glaucoma. But if it is not leaving an RNFL defect, it has got nothing to do with the glaucoma. Then coming to the peripapillary atrophy, you have the alpha and beta zone, but this is one of the things which we do not use clinically much. The beta zone, we say that if there is an enlargement of the beta zone, you have it is increased in glaucoma. Now coming to the vascular changes, you can have the barring of vessels, which means that once this rim is receding, the vessel seems to be hanging. You can have the nasalization of the vessels. You can have the bionetting, which is the double angulation of the blood vessel. That is because of the deep cupping, the vessels are just going down, climbing through the wall of the cup and then coming out. That is a double angulation. This is also known as a bionetting. And then we have the laminar dot sign. But these vessel changes are not specific of glaucoma, but it can be seen in glaucoma. It just indicates that there is a deeper cupping. Now, the most important thing after NRR is a retinal nerve fiber layer defect. So you see the RNFL, you know that the retinal nerve fiber layers are arranged. The papillomacular bundle is straight, the rest are all in the arcuate. So the RNFL defect will come in the same pattern. So if you see this, you can see that there is an inferior wedge-shaped defect. The RNFL defect will be seen as a darker area. So it can be either slit defect coming from the disc, or it can be away from the disc. But in glaucoma, it will be coming from the disc, and it can be slit or a wedge, or it can be diffuse defect. Again, in this case, you can see that there is an inferior RNFL defect. Also, it is closer to the papillomacular bundle. So you get an idea, when once the RNFL defect is closer to the papillomacular bundle, it can be an NTG pattern. Now another example showing the superior and inferior RNFL defect. What you need to know is, once you see the RNFL defect, go and see the disc also. It has to correlate. So in this case, it may look like there is no RNFL defect, but if you see carefully, the whole upper area, the RNFL defect is a diffuse RNFL defect. Also correspondingly, superior NRR is also thinned out. And once you have a total cupping, it will be a diffuse loss of nerve fiber layer. So this is one of, if you see this case, you can see that there is a definite beautiful RNFL defect that you see. But you look at the disc, you can see that there is no cupping. It's only a 0.2 cupping, and there is no notching. So this case, it is not associated with glaucoma. So just by seeing an RNFL defect, you cannot diagnose a glaucoma. RNFL defect can come in other conditions like hypothyroidism, or it can come in diabetic retinopathy, early diabetic retinopathy, and other neuro conditions also like Alzheimer's disease or stroke, which will not have any disc changes. And something like this, the slit defects, if you can appreciate that slit defects which are not coming from the disc, these kind of RNFL defects are more in favor of nutritional optic neuropathy. It can be vitamin D deficiency, or you have to go ahead and look for the thyroid status. So this is also helpful. So I'm summing up, the most important thing in clinical glaucoma diagnosis is seeing the disc. Only if you see the disc and you pick it up properly and at the correct time, you're going to go and do the investigations. See the NRR, see the notching, the RNFL defect, as well as the progression, and then go ahead and look for the other findings, and do not miss the glaucoma. Thank you.
Thank you so much, Sweta, for your wonderful presentation.
Thank you, sir.
We know that the optic disc evaluation is the important point when you are examining the fundus. We all know that the intraocular pressure is just a risk factor in glaucoma, because somewhere around 40% of the people, or even more sometimes, have a normal intraocular pressure, but they have a glaucoma. So examination of the optic nerve head carries a lot of weightage in diagnosing and treating the glaucoma, because the progression also is seen in the disc. Many times when the patient is doing the visual fields, he may not be able to do it properly. Of course, the VOCT gives a little better ones. So examination of the optic nerve head with a wide open mind and taking a fundus photograph for a detailed, and the image becomes much bigger. You can magnify it to 300 times, and examination can be so easy for you. So going in for a fundus photograph in every glaucoma patient seems to be an important area to think of. So thank you so much, Sweta. You can just exit your presentation. Dr. Krishnadas or RK sir, if you have some comments, please add on. And the next, Dr. Sweta has
go ahead with the speakers.
Dr. Sweta has completed 2 years of her fellowship in glaucoma, and she is the consultant currently. And the next speaker is going to be Dr. S.G. Priya from E-Road. Before that, I would just request Dr. Krishnadas and RK sir to give their comments.
Satyan, we'll go ahead with the topics, the speakers, so that at the end of the speeches, we will go for the panel.
Okay.
That'll be better.
Yeah. Sure. So we have from RSNI Hospital, E-Road. Dr. Priya also has completed her short-term training in glaucoma at Arvind Coimbatore when I was there. Now she is a consultant at RSNI Care as a glaucoma consultant, and she has a good amount of experience in glaucoma now. Probably now it is 15 years or more than 15 years now in glaucoma she has been practicing. Over to you, Dr. Priya. Gonioscopy is again another important area for us to understand, because in India we have almost equal number of open angle and angle closure, and of course we have many surprises in the angle. So Dr. Priya can throw us some light on that. Over to you, Dr. Priya.
Thank you, sir. A very good morning to all the stalwarts in the forum and all my colleagues.
Priya, just yeah.
So can you see my presentation, sir?
Yeah, just make it as a full slide. Yeah, good. We can see. Go ahead.
So, gonioscopy, as I said, is a very important tool in everyday glaucoma practice. Even after the advent of so many gadgets like anterior segment OCT, pentacam, and everything, gonioscopy still holds a gold standard for clinical evaluation of the anterior chamber angle. So it's important that every ophthalmologist know how to do gonioscopy, and mainly how to interpret the gonioscopic findings that we see. Gonioscopy is very important to classify glaucoma, whether it's an open angle or an angle closure disease, so that the planning we can manage appropriately. Angle closure disease management also depends on the gonioscopic findings. We can differentiate whether it is appositional angle closure or cynical angle closure only when we do gonioscopy, and also helps us to avoid the wrong diagnosis. I've seen many people being referred as normotensive glaucoma where the angle was narrow but missed because gonioscopy was not done. And in glaucoma patients, gonioscopy should be done in all patients at the initial visit and in all glaucoma suspects. And it needs to be repeated at periodic intervals, because as the patient ages and the lens changes occur, the configuration of the lens changes. So over time, even if the angle was open to start with, it may become narrower as the patient ages. So it should be repeated periodically. As we all know, there are two types of gonioscopes, direct and indirect. Direct gonioscopy is mainly used for angle procedures and surgeries, and indirect gonioscopy is used for clinical diagnosis. So I'll restrict my talk to indirect gonioscopy today. And there are so many types of gonioscopic prisms available for clinical evaluation, but these two are the commonly used ones, Goldman and Sussman 4-mirror lenses. There's a short comparison between these two lenses. Goldman mirror lens needs coupling fluid. The contact diameter of the Goldman lens is larger, whereas the Sussman lens, the contact diameter is smaller. And the radius of curvature of the Goldman lens is more than that of the cornea. So it needs a coupling fluid. And the disadvantage with the Goldman lenses are indentation is not possible as it has got a larger contact diameter and steeper curvature. This is a short video showing the images of these two commonly used lenses. This is the Goldman type lens with a larger contact diameter and a steeper curvature, whereas the Sussman has a smaller contact diameter with the radius of curvature that matches the cornea. So indentation is possible only with Sussman type of lenses. And it's also clinically easier to use as the Sussman lens does not need any coupling fluid, and the technique of insertion also is very easy. Before we start doing gonioscopy, we should assess the anterior chamber angle depth with the slit lamp. The commonly used method is von Erich's grading. And I would advise all the beginners to start doing gonioscopy in normal looking anterior chamber eyes, so that you get familiar with the normal angle structures. Then as we do gonioscopy in narrow angles, we will know what we are missing. But I've seen postgraduates and juniors start doing gonioscopy in angle closure straight away, so they won't know what they are missing. So this is the image showing von Erich's grading. In the first picture, in von Erich's grading, we have to make a thin slit at the limbus and compare the thickness of the cornea with that of the anterior chamber depth in the periphery. In the first picture, we can see the space between the iris and the cornea is very narrow. There is almost iridocorneal contact. And grade 2 is 1/4 to half of the thickness of the cornea. And grade 3 is more than half of the thickness of the cornea, the anterior chamber depth. And grade 4 is a wide open angle. So in von Erich's grading, grade 1 and 2 eyes will have more chance of having a narrow angle and occludable angles. And once we do the gonioscopy, we should know how the normal angle structures appear. This is a picture showing the normal angle structures. The first faintly pigmented line is the Schwalbe's line. The second pigmented line is the pigmented part of trabecular meshwork, and in between these two we have non-pigmented part of trabecular meshwork. Next comes the scleral spur, and next comes the ciliary body band. The color of the ciliary body band is little darker than the iris color. I've seen many juniors having confusion where to look for the angle. When we put the gonio lens, you look at the pupil. Here we have the pupil. So the opposite to that is the iris root. And there you have to look for the angle structures. And in younger patients and patients with non-pigmented angle, it will be difficult to identify the Schwalbe's line and the angle structures. So many a times a non-pigmented angle is mistaken for a closed angle. So in that case, corneal wedge helps. So Schwalbe's line is where the cornea ends and the sclera starts. And that's called the end of the Descemet's membrane. So in this picture, we can see a beautiful corneal wedge where both the layers come and meet. This is the Schwalbe's line, and below this is the iris root. In between, we see the angle structures. And the general guidelines for doing gonioscopy is we have to do the tonometry prior to gonioscopy, because doing gonioscopy will push some amount of aqueous into the trabecular meshwork and will cause falsely low IOP if the IOP is measured after the gonioscopy. So do the tonometry prior to gonioscopy. And the gonioscopy should be done in a dark or dimly lit room and use a short, narrow beam which does not fall on the pupil. Because if the ambient light is very bright, it may cause pupillary constriction. And if we put a broader beam which falls on the pupil also, it will constrict the pupil and pull the iris root away from the angle and cause artifactually open angle. And also when we do gonioscopy, avoid pressure on the lens. That will cause DM folds and make it difficult to visualize the angle, or it may again artifactually open up the angle. In the technique, we have to seat the patient comfortably first, then anesthetize both the eyes adequately and place the gonio mirror gently over the cornea. Adequate illumination with a thin beam which does not fall on the pupil, and view the angles. And most importantly, we need to record the angles findings in all the 4 quadrants. And in gonioscopy, when we use the indirect gonioscopic prisms, we need to remember that the images are inverted but not laterally reversed. Whereas in retina, it is inverted and laterally reversed. That means whatever we see in the inferior mirror is in the superior angle, but whatever we see nasally is actually in the nasal side, and what we see temporally is actually on the temporal side. So there's a short video showing the technique of insertion of the gonio prisms. This is a Goldman single mirror lens. It needs a coupling fluid. We need to hold both the lids gently and insert the lens without any air bubble. And one disadvantage with this lens is we have to rotate the lens for visualizing every angle in the single mirror or 3 mirror Goldman lens. Whereas in Sussman lens, we have 4 mirrors, so we need not rotate the lens, and the technique of insertion is negligible. Just keep the lens over the cornea and start visualizing the angle all in one go. So practically, and Sussman can be used to do indentation gonioscopy. Indentation gonioscopy will give a lot of valuable information in angle closure disease, because without indentation, we won't know whether it is appositional angle closure or synechial closure, and the entire management differs based on that findings. So practically nowadays, I think everybody is using 4 mirror indirect Sussman lens. And the other some maneuvers we can use to see the angle are over the hill gonioscopy and dynamic gonioscopy. Where some patients will have a convex iris with a steep configuration. There we can use over the hill gonioscopy. That is, we ask the patient to look in the direction of the mirror that we are seeing, and that will enable us to view over the steep configuration of the iris. And dynamic gonioscopy is to see the effect of pupillary constriction on the angle depth. When the pupil constricts, the angle will open up. This is a short video showing how the angle opens up on indentation. You can see now, you don't see any angle structures as the lens is being indented. We can see the trabecular measure showing up. And once we visualize the angle structures, we need to grade the angle, because it helps us to objectively have a documentation of how open the angle is. And this is a commonly used modified Schafer's grading system. There are so many other grading systems available, like Schei's grading system and Spathe. Spathe is more gives more information about the status of the angle. Apart from the angle opening distance, it also gives us the configuration. We can record the configuration of the iris and the level of iris root insertion. And the technique is very simple, but we need to have a knowledge about the commonly seen angle abnormalities. Apart from the open angle and closed angle, we see a wide variety of angle abnormalities when we do gonioscopy. So we need to have knowledge about that. So to interpret what we are actually seeing. This is a picture showing a closed angle. I have just put an open angle picture here to compare. We see all the angle structures here, whereas here we see only the iris root. We do not see any of the angle structures. So this is how a closed angle appears. And another doubt commonly the postgraduates and youngsters have is how to differentiate the peripheral anterior synechiae and the iris processes. The picture on the right shows the iris processes. The iris processes are slender filamentous structures which straddle the angle, whereas the peripheral anterior synechiae are a broader attachment of the iris to the angle. The pictures on the bottom side shows a broader synechiae. And this is another image showing angle blood vessels. This picture shows a normal angle vessel, which is a larger in caliber. And this picture shows neovascularization of the angle, where we can see fine arborizing vessels. It actually is seen as somebody has painted the angle with the red color. You won't be able to see the individual vessels actually. Sometimes it can be associated with the microhyphema. And this is a gonioscopy of a patient with pigment dispersion syndrome, where we can see a densely pigmented Schwalbe's line, the pigment, trabecular meshwork, everything is densely pigmented. This can be seen in sugar exfoliation, pigment dispersion syndrome, and in some cases with injuries, wherever there is pigment dispersion. And this picture shows a patient with angle recession. Angle recession is actually an irregular widening of the ciliary body band. Here you can see this is the ciliary body band where it is being widened irregularly. And this is a picture showing iridodialysis, where we can see the ciliary processes actually through the dialysis part of the iris. This is a cyclodialysis cleft. Here the cyclodialysis cleft is seen as whitish region, whereas in iridodialysis it is brownish and we see the ciliary body there. And this is another picture showing angle tumor and cyst. This is a foreign body in the angle. We can also assess the trabeculectomy ostium in post-trabeculectomy patients, whether the ostium is open or not. You can see the ostium here on the scleral side. You can see the peripheral iridectomy here. And this patient with congenital aniridia, where we can see a rudimentary stump of the iris and the ciliary processes through it. And the common contraindications to doing gonioscopy are as that of any other contact procedure, like any corneal injuries, aberrations, laceration, open globe, and any infections that can be transmitted, and corneal edema, bullous keratopathy, basement membrane dystrophy. All these are contraindications to doing gonioscopy. And how are we going to disinfect the prism? We can either wash with soap and water and clean with sterile swabs, or can soak the lens for 5 to 10 minutes in fresh 1 in 10 sodium hypochlorite solution, or 3% hydrogen peroxide also can be used. And the direct surgical gonioscopes can be autoclaved in ethylene dioxide. Thank you.
Thank you so much, Dr. Priya. Wonderful presentation and nice gonio pictures. Well done. Thank you so much. Just stay there. Dr. Sweta and Dr. Priya, stay there, because when we have the panel, we'll be calling you back.
Yes,
as there is
Satyan, I just want to make one
shortage
comment.
of time, we'll move on to the next.
One comment.
Sorry, sir.
Both the talks were really
Yes, sir.
awesome. Both Sweta and Priya, awesome
Thank
talks.
you, sir. Thank you, sir.
Fantastic. I learned a lot. Thank you very much.
Thank you, sir.
Yeah, valuable comments from President for both of you. We'll have visual fields as the next talk. We all know Dr. Rangaraj very well. He is one of the pioneers in the area of visual fields. I'm happy to say that I have learned quite a lot of lessons on the visual fields from Dr. Rangaraj, especially on the octopus visual fields, where he has contributed to the book which is being released by the Hag Straight. So over to you, Dr. Rangaraj. We will be very glad to listen to you, and we'll be happy to learn a lot from you. Over to you.
Thank you, Dr. Satyan. I'll begin my talk. I'm just sharing my screen. And it's always a pleasure to give my presentation. And thank you, Dr. Satyan, Dr. R.K. sir, and Krishnadas. I'm just enlarging it. You're able to see my screen?
Yes, sir.
Thank you. So what I decided was that I'll give some practice pearls for visual field interpretation, because everybody seems to have difficulty with that. So what I thought was I'll give 7 practice pearls. Now, why 7 practice pearls? Because we use a 7-in-1 printout. So it's very easy for us to remember that. And in the 7 practice pearls, I would say that administering the visual field is probably one of the most important. I'll go through the next to the slides as I go through the presentation. Now, when we administer the visual field, this is very important because it's a subjectively objective test, and it is a team which we have. So in the first loop, and the 3 important actors are the doctor, patient, and the examiner. In the first loop, we have a certain set of things which we need to do. And in the second loop, a certain set of training which we need to do. So what is in the first loop? The doctor emphasizes the importance of the test to the patient and make them understand the process, what is happening, and encourages the patient to ask questions. And the optometrist or the examiner will administer the test, do proper data entry, and comment on the test, because this is something we are not seeing in our cabin, and whether the patient was nervous or whether the patient was tired or fatigued. And then comes the second loop. Now, in the second loop is also very important because it involves a certain amount of training, which you give to the optometrist to focus on that. And when they do a good job, we should say that they have done well and encourage them. And that in turn makes the examiner or the optometrist to provide clear instructions and encouragement. And what I tell my optoms is to supervise the test completely and not go and do one more refraction or something like that. And once we show the intent and the need to do that, the patient understands why this is being done, and they are motivated to do the test, and they know the importance of this test. It's not like passing or failing. I tell my patients, it is mainly you're playing a video game. Think of it like that, not an examination you need to pass. And that changes the perspective when they do the test. Always pick the right test and don't overlook central fields. So I'm just going through this in a very quick manner. So the paracentral fields and nasal step areas are very important. And we use predefined locations based on the nerve fiber and an economy of stimulus presented per location to make it short. Now, these predefined locations can be based on the nerve fiber, as in octopus, like in the G test locations, or in the HFA 24-2. This is actually an off axis. It gives you a foveal resolution of 4.2. So hence many people wanted to do a 24-2 and a 10-2 to get better results. But the good news is that now HFA has decided that they need to also look at the paracentral areas, and they have what is called as a HFA 24-2C. So they created 10 more central points. So these 10 more central points and this HFA 24-2C is compatible with the previous data. So that's what they have promised. So apart from octopus, I also read up HFA. So when we go to the clinic, it translates into what are you going to use? What is the strategy? You're going to use theta standard, or you're going to use dynamic. These are how we test those isopters which we have already predetermined. And the trend today is to pick shorter strategies. So in CETA, you have the CETA fast and the CETA faster, which is in the newer HFA machines. They don't consider the false negatives. This is very important. We are trained on the reliability indices and saying, you know, this, don't consider it. I'll come to that in the next few slides. And top, I use top for diagnosis, follow-up, and neurological fields. Now, shorter testing times are patient-friendly. You can just see the difference in time. And the net result is when you look at the statistical output, there's not much difference. So there's a lot of difference between 16 minutes and 4 minutes. The incentive for the patient to come back for follow-up, especially when you want a frequency of, say, approximately 3 per year, they're not going to come back if they have to sit down for 20 minutes. They won't come back. And same thing with top and dynamic. I find top is faster, gives almost approximately the same kind of results, except that the depth of the SLV or the PSD is not so deep. And if you have a patient like this doing for 22 minutes, they're unlikely to come back, and the same patient does it in about 3 minutes time. You must also know when to modify this testing strategy. Suppose you have a patient with a slightly lower vision, say 6/18, 6/24, and advanced, change the stimulus size. This is something which we don't do. I encourage you all to do it, and then see for yourself the result and the happiness the patient has when they come for follow-up, especially for advanced glaucoma. Stimulus size 3 will look something like this, and the stimulus size 5 will look like this. Now, you have better, see, you have already made the diagnosis, and we don't need a statistical validation for this. What we are doing is following up the parameters. That is what we're doing over time. And just to give a perspective, you can fill in about 10 of the size 3 into a blind spot. And in case of size 5, you can fill in about 3 of them. Now, why do we want to use size 5? Because it overcomes the floor effect with the larger stimulus, and it's used in advanced visual field defects. It also reaches some amount of retinal ganglion cells which are left. And if you see the size 3, it is hardly reaching anything. So the patient is very discouraged when they see the report, so they don't come back. So to encourage them, use a size 5 when the vision is low. That is a clinical decision you've got to make, and it is within your thing. Then interpreting the result is very simple. We have the classic 7-in-1 printout, and we also have the 9-in-1 printouts from the iSuit. It gives you what's called as the cluster analysis. These are local MDs, sector MDs. So it actually tells you from which sector there is a, some amount of, when you see these numbers which are prominent other than the plus, you know it is worsening over there. And then of course you have a structural orientation, and the length of this red indicates how deep the defect is. So it gives you a structural orientation. What we are looking for in glaucoma and static automated perimeter today is glaucoma. We are not using so much for neurophthal and things like that. We just do it as a routine to fill in the file. They have better techniques to do now. So what we are looking for is POAG, and it's all in set patterns. So what we are looking at is pattern loss. So if you're in a busy clinic and then you want to look at the pattern of loss and you just want to see how it is, go ahead and use the statistical outputs. So you have the total and the pattern deviation plots, you have the probability and corrected plots, and these give you the refined essence of the 7-in-1 printout, basically. So this tells you that you have some paracentral areas which are affected, and you have to correlate it clinically. So it tells you, it gives you an idea. The basis of all this is the raw values. See, the raw values, when you look at it, you find that the central values are high and the values in the periphery are lower. It forms like a hill. So this is the hill of vision, and that's the same thing with the HFA too. So once you construct this hill, you know how it looks. So it gives you an approximation of that. And once you have these raw values, you correct it for an age. So when you correct it for age with a normative database, you get an indexed value. In the Octopus, you have a choice of having your grayscale, either grayscale or color scale, coming from indexed values. You can take it as a total deviation plot, or in Octopus it is as it's over here, and it does not come from the raw values because it removes the clutter. So once you have the actual comparison, which is compared to the age, it removes the clutter because these values become normative, and you find that this is the topography of the defect. And once you take the diffuse defect, which in Octopus derived from the baby curve, and in case of HFA, it's the 85th percentile or the 7th most sensitive, and it's corrected for age as well as diffuse defect. So you get both the numerical value as well as the plot. And you get, of course, the GCT. It's in Octopus, it is called as a glaucoma cluster test, and it gives you plain language outside limits, and it also gives you a Brucini staging, and it's called a stage 1. So these things come automatically. This is based, the Brucini staging is based on the MD values and the SLV or the PSD values. And this is how the HFA looks, which is pretty similar, except that the strategy may be a little different, but the presentation is almost the same. So I just give a few tips for interpreting the perimetry data. So distinguish between normal and abnormal. You don't need to go by any standards. So all you need to look at is grayscale. Yeah, you find some areas which are showing some likely abnormality, and then you do find the statistical output giving you 5 random distributions of abnormal location. It fits into the pattern that it's probably significant, but it's likely to be normal because these are random points. They don't have a pattern. But when you take the second one, these are the likely abnormal locations, and it seems to form a pattern which forms like a partial aqueous defect. And it gives you all the statistical output which says that, yes, it looks like abnormal. So you investigate further. So this is where your structure and function correlation starts, and it's likely to be abnormal. And look at the topography of the defect. It gives you the percentage of normal. So if it is white, it's 0 and 10, and darker as it becomes, darker is worse. And of course, if you want to look at the numbers, this is the numeric deviation from the normal. And once you correct the diffuse defect, this is what you get. So from 22, you get the 16. And these are presented in a very simple manner so that there is not too much of numbers around. So when it is plus, you know, these are normal within the normal bandwidth. 22 tells you that it's the visual field loss. Larger the number, it's worse. And the absolute defect means the maximum lighting, they're not able to tell. They're not able to discern that there is a stimulus even presented. And the cluster defect in 9-in-1 is very nice because it gives you a sector in which there can be loss. So for example, in this place that you have 6, 4, 3, 2, 5. Now 4, 5 are within normal, but 6 is definitely abnormal. And the statistical output tells you that only one area is marked as abnormal. But when you look at the average, the local MD, it goes to a significance of 1%. So you know that you're looking at something and some abnormality, and that brings your attention to look at the optic disc, like the previous speaker was telling. So it gives you a directional sense. And for example, this high sensitivity of clusters is very important because once you have 2 paracentral locations looking like this, which is P about say 5%, which means in 5% of population it is normal. But when you take the cluster, it becomes a supernasal cluster, which is significant at 1%. So you'll definitely find something going on in the optic nerve. And how do you bring the spatial relationship between the visual field and the structural result? So if something is there in the upper field, you have the retinal ganglion cells, which is 13 dB here, which was tested, and the fiber angle, which is the inferior temporal area, which is damaged. So that's the Wallerian degeneration, which you see. So the polar analysis gives you a structural extrapolation of the visual field. So if you have a comparisons grayscale like this, and this is your statistical output, and this is where the polar analysis comes. So it gives you the lateral inversion, and you then see it with your fundus picture. So you know where to look for the nerve fiber defect. So what's the role of indices then? The summarizes the visual field, and it stages the visual field. It tracks changes over time, but it has no diagnostic value. So these numbers as such do not have a diagnostic value. We need to avoid common pitfalls like learning effect, fatigue. 15 minutes later, you make the patient do 3-4 tests on the same day. It's not going to work. Ask them to come back another day. And please enter the correct age. Now, correct age, this is a normal result. But if you have an incorrect age of 88, it's going to be super normal. And if you put it at 18, it's going to be definitely abnormal. Artificially good result and artificially worse result. And same way, look for the vertex distance. That's the distance from the cornea to your correcting lens. You can, if you move it forward, you're going to get a rim artifact. And of course, try and avoid astigmatic lenses which are shaded this way. So they also creep in all these effects. So doctors should go and look into their trial lenses which has been provided to them. And loss of fixation occurs in HFA. In octopus, it does not. But when that happens, you get an artifactual defect, which is projected elsewhere. And small size pupil, definitely the sensitivity becomes less. And if it's a normal pupil, it should have the normal sensitivity. Please do not dilate and do, your resolution will come down even further. Now, what about high false negatives? I would be wary of taking out the high false negatives because of 2 reasons. One, there is already pathology here, and anything abutting the pathology will definitely have defects. So the frequency of seeing curve is flat. So which means you have a variability of 6 decibels. Your normal variability is just about 1.5. So you will have high false negative, and it is a good baseline. Do not discard it. High false positives, I would discard. Then you have masquerading retinal problems like these. You can have something like this, and when you look at it, you have a choroidal patch, a heel choroidal patch. And of course, optic nerve conditions like this female who was diagnosed as glaucoma elsewhere. She came with visual fields which had definitely some kind of visual field defect inferiorly. But when you look at both the optic disc, the red free, you find that there is a nerve fiber loss in this superior-nasal area. And definitely there is a superior-nasal retinal nerve fiber thinning. I would just like 1 minute, please. And this is a very underappreciated differential diagnosis for glaucoma. It's called the superior segment optic nerve hypoplasia, prevalence of less than 1%. You don't need to have all of them. Make sure you're following up glaucoma. Use progression tool analysis like the global indices, the VFI, SLV, the local defects. Now, the event is very important. It shows that changes occurred from the previous, and the measures, and if it's a trend analysis, it measures the rate of change of decibel per year. Increase the frequency of examination depending on the perceived risk you see on the optic disc. For example, if you do 1 examination a year, you're going to find 2 decibels, you're going to take 5 years. But if you do 3, you're going to find that in 1.7. Always correlate structure and function. And you have something flagged at 5%, then you know that there are splinter hemes and the RNFL loss. And the difference map definitely tells you that there is a sector loss. Use the 12 sector to analyze this, and you definitely know that something is going on. So the basis is a good baseline, reliable visual fields, customize the frequency depending on the patient, and use color, pictures and OCT to document your findings. And remember these 7 points, they're very important. Thank you very much. You can download this book for free. Just use search term visual field digest octopus. Thank you.
Thank you so much, Dr. Rangaraj, once again for a very wonderful talk. Because there is so much that we need to learn in visual fields, and we keep on learning. I'm in glaucoma, in ophthalmology so many years, still we keep on learning the visual fields. So we'll have the discussion again. Now over to Dr. Pavan. Pavan Kumar is a glaucoma consultant at Arvind Pondicherry. He is going to give a presentation on the OCT in the pre-perimetry glaucoma and also in the early diagnosis of glaucoma, how much it can be used. Over to you, Dr. Pavan.
Thank you, sir. I hope I'm...
you can see. Just make it as a full slide.
Yes, sir. So first of all, I would like to thank Krishnadas sir, RK sir, for providing me this opportunity to present in this beautiful Connect series. And I also thank Dr. Mohan Rajan sir for arranging this tirelessly and continuously. Let's go into my talk. So my topic for today's discussion is optimizing OCT technology. How do we manage suspects and pre-perimetric glaucoma? The previous talks have been clearly defined and clearly showed how do we diagnose glaucoma and how to go ahead when we diagnose glaucoma. It's a straightforward, but my topic will be just pre-perimetric. Before the established glaucoma is there, how are we going to diagnose it using OCT? So all of us know that glaucoma is characterized by progressive dysfunction and degeneration of retinal ganglia cells that leads to structural changes to optic nerve head and inner retina, thereby leading to visual function loss. The key to diagnosis is recognition of morphological changes to the optic nerve and retinal nerve fiber layer. Early diagnosis and treatment of glaucoma is important so that we can reduce the risk of progressive and irreversible visual loss. Although the diagnosis and follow-up assessments of glaucoma are based on anatomical and functional damage, the relationship between these two has not been yet clearly defined. So an analysis of the relationship and functional glaucoma could facilitate evaluation of structural and functional tests for early diagnosis of glaucoma damage and for accurate staging. As the damage progresses, there is correlation between these two, but however, the structural changes seems to be detectable before the functional ones. When there is a scenario where there is raised IOP, there is optic nerve head changes and a corresponding visual field defect, the diagnosis is straightforward. If there is raised IOP with only optic nerve changes and there is no visual field defect, we call it as pre-perimetric glaucoma. And in a scenario where there is either a normal IOP or a borderline IOP, but there is some optic nerve changes which is not very clear, visual field is normal, then we brand them as glaucoma suspects. And detecting early glaucoma is challenging because there is wide variation in normal optic nerve head appearance, and sometimes it becomes very difficult to say whether it is physiological or pathological. So we will always be in a dilemma whether to monitor these kind of patients or should we treat them. In this place where the ocular imaging devices comes to role, in the last 2 to 3 decades, there are various ocular imaging devices has been developed, and OCT plays a very important role. It was first described by Huang and colleagues in 1991. It is similar to BScan, where only is it uses light waves. It's a non-invasive, non-contact technique, and it uses the differences in optical properties of tissue structures to create an image. We all know how the OCT works. It's based on Michelson's interferometer principle. And we have time domain and spectral domain OCT, where spectral domain OCT is faster to acquire. However, both will give equal results in diagnosing early glaucoma. So this is the printout of a time domain OCT, and this right one is the spectral domain. So why do we prefer OCT? OCT is preferred because it is versatile. We can combine with along with the posterior segment retina surgeon to have this mission, and then we can even image optic disc, RNFL, and macula. It gives a direct measurement of RNFL thickness, and the measurements are not affected by refractive status, axial length of the eye, or the presence of early to moderate nuclear sclerotic cataracts, and we don't need a trained technician to get an OCT imaging. So these are the parts of the OCT printout, starting with the key parameters, and then RNFL thickness map, RNFL deviation map, RNFL quadrants, and also RNFL clock cover thickness, along with the TSNIT graphs and NRR thickness. So we need to look into each and every part of this OCT printout, and the major advantage is it compares with the normal age matched control, where we can compare and say whether the findings are fine in the normal people and how much percentile of the people it is found. So when we look at the studies, OCT has got a good sensitivity and specificity in differentiating glaucoma size from the healthy eyes. However, it varies with the severity of the disease. It is highly variable, normal optic nerve head appearances. So we rely more on RNFL for a good parameter. So I'll describe few clinical scenarios where OCT can be very helpful. This is scenario 1, where the patient was referred to our clinic because the patient had a higher cup disc ratio. As we can see, the cup disc ratio is quite high. It is noted as 0.74 and 0.75 in both the eyes, but RNFL is perfectly fine, and even the field test appears fine. So this is just a physiological cupping, and we don't have to do anything for this patient. Another scenario where, if you can see, the patient was referred for optic disc asymmetry. The left eye cup is bigger than the right eye cup. There are changes in the optic nerve head parameters, but when we look at the RNFL thickness, it falls within the normal range, and there are no other risk factors. Even the visual field is normal. We just have to monitor this patient. There is another scenario where this patient was referred because they were thinking there is a notch-like appearance in the right eye, optic nerve head, where we went and did OCT in this patient. As we can see, there is some cupping and thinning of the neuroretinal rim, but overall, when we take the optic nerve head parameters, the RNFL quadrants and RNFL clock hours, everything falls within normal. So we just have to closely monitor this patient, no need to treat, and just consider this as a dissuspect. Another scenario, again, the patient was referred for RNFL, referred for optic disc asymmetry. The left eye cup is little bigger than the right. Factors, whether there's any raised IOP or any family history of glaucoma. Patient did not have anything. So we just kept this as a patient of glaucoma suspect, and we can monitor this patient closely. Another scenario where, again, the right eye optic nerve cup was a little larger compared to the left eye. The fields were almost normal. And when we did OCT for this patient, as we can see, the optic nerve head and RNFL parameters are definitely altered in both the eyes. The perimetry is again normal in this patient. Patient had little higher intraocular pressure, strong family history of glaucoma. Hence, we considered this patient as a pre-perimetric glaucoma, and anti-glaucoma medication is started in this patient. The scenario where the optic nerve head had a clear-cut notch and corresponding RNFL defect. Perimetry shows a clear-cut defect in the right eye. Very good correlation between the OCT and the early glaucoma and aging should definitely be. This is another scenario where a patient was referred for higher IOP in the right eye. He had a little cataract, so the fundus was not very clearly visible. Right eye optic nerve curve was definitely bigger compared to the left eye. So right eye, definitely there is glaucoma. We need to know whether the left eye also has glaucoma and should be treated, even though IOP is normal. When we did a visual field, right eye showed us an paracentral defect. Left eye visual field defect was doubtful. We went and did OCT in this patient. Right eye parameters are definitely altered. Left eye, there is some alteration in the optic nerve parameters, but OCT RNFL was quite normal. So we can just go ahead and treat the right eye closely. This is another scenario where right eye has an established glaucoma, but we are not sure whether left eye also has glaucoma. Here, right eye shows advanced visual field defect. Left eye, there is a little doubtful defect. When we did OCT in this patient, right eye definitely showed bipolar thinning, whereas left eye showed early RNFL thinning in the superior temporal quadrant. So definitely he needs anti-glaucoma medication in the left eye. Another useful another major use of OCT is assessing progression of glaucoma, where we can use a guided progression analysis software for this. This needs two baseline OCT images, and then whatever the images we get further, it can be compared with the two baseline images. The upper part of the image of the printout shows the images of the optic nerve fiber thickness, and the below it shows the changes in the nerve fiber thickness between the optic nerve examination. This is the two baseline test, and this is the next test, that exam 3, which is done. So this test will be compared with these two baseline, and it also gives an estimation of the average RNFL thickness and how it is changing. If there is any changes in RNFL thickness, then it is going to indicate by showing 3 color coding. If there is an yellow color coding is shown, then it means there is possible loss. If it shows a red color, then definitely there is likely loss. And if it shows a violet color, then that means that the thickness of the RNFL is increased. So we can use this GPA program to monitor the patient when we are suspecting there is a progression. And there is one more use of OCTs, ganglion cell analysis. The GCC ganglion cell complex consists of 3 layers, that is nerve fiber layer, ganglion cell layer, and inner plexiform layer, which contains the axons, cell bodies, and dendrites of the ganglion cells, the loss of which is typical of glaucomatous optic neuropathy. As we can see, the glaucoma has got a thinner GCC compared to the normal GCC. So this can also be used in diagnosing early glaucoma. Even though the RNFL parameters are normal in this patient, if it just did an GCC thickness analysis, there is a slight alteration in the right eye. Left eye also shows some amount of difference. So these patients need careful monitoring, and then based on the risk factors, we can even initiate the therapy. So in conclusion, OCT is very useful in diagnosing glaucoma, especially in a new patient. If there is a normal scan, very unlikely that the patient has glaucoma. It is great at separating physiological cupping from early glaucomatous changes. In pre-perimetric glaucoma can be easily identified. It's got a very high negative predictive value. If the scan says normal, it is almost certain that they don't have glaucoma. Thank you, sir.
Fantastic, Pavan.
Thank you, sir.
Super.
Sorry, sir. Yeah, sorry, sir. Just thank you so much, Pavan, for covering the OCT.
Thank you, sir. Thank you.
Satyan, your voice is not.
We'll just move on to the management part of it. Pavan, you can stay back, so we'll have a discussion.
Sure, sir.
Audio is not clear, Satyan.
Dr. Prasanna Venkatraman from Chennai to talk about the.
Oh, it is better.
Yes, sir.
Satyan, your audio is not very clear, so it's breaking.
So can you hear me, sir?
No.
Okay. Yeah.
Can you hear me now?
Yes.
Sir, can you hear me?
Yes,
Satyan, please go ahead.
Yes, Satyan, now we are able to hear you.
I don't know if Satyan has lost connectivity. I now request Dr. Prasanna, who is our young budding glaucoma specialist at Aravind Eye Hospital, Chennai. He has wide experience in publishing too, research and publications. I have requested him to talk on critical aspects of medical management of glaucoma. Prasanna, go ahead. We will see if Satyan can join us.
Thank you, sir. Good morning, everyone. I'm Dr. Prasanna. So my talk is titled IOP Drop Choosing It Right. So this is the timeline of the introduction of many glaucoma drops that we have, right from the oldest of pilocarpine to the latest, the fixator combination of metasulfite and latanoprost. So we have wide options to choose from to treat our patients to control the glaucoma pressure. We need to set a target because IOP is the only modifiable risk factor that we have in glaucoma. So target pressure varies between patients within the same patient during the clinical course. So the patient is from early disease or advanced disease. It's not an exact number, but it is only an estimate at which further damage or progression has and vision remains stable without affecting the quality of life. This is really important. We don't have to chase the target, but we have to always consider the quality of life of the patient when deciding the target pressure. It is quite reasonable to start with a 20 to 30% reduction and titrate later based on the response. To have a estimate, we can choose the number of about 18 in early glaucomas, moderate about 15, and advanced 10 to 12 millimeters mercury. So how do we set a target? So setting a target has so many variables. So we have to decide on based on the severity of glaucoma, the based in untreated IOP at which damages happen. So this is critical because in NTG damage happens at lower pressure. So this we have to consider. So next is the patient life expectancy, the current rate of progression based on fields, the status of the fellow eye, and family history of severe glaucoma. So this figure is from the EGS guidelines. So we can see patients at different timelines. So the denominator everywhere is the blindness. Of all the parameters, the only thing that is really critical is the patient life expectancy. So the patient is really young, we have to give it our all and start them on maximum medications to prevent them from going blind. So the patient is old, we have to consider the quality of life and give our medications accordingly. So we have started our drop and finally we realized the IOP doesn't drop. So not go into the details of each mechanism of action of each drop, but we'll have an overview as to what to do when the IOP doesn't drop. So we have to check the complaints first because this is really critical. So we have to make sure the drug actually goes into the eye. So we can check the bottles, we can ask the patients. So that is really critical. Then we have to give adequate time for the drug to act first. Because when we start, especially prostaglandins, when we start and call the patient in 3 days, and when we don't find IOP drop, we can't label them as no response. So since we have only limited drugs in our armamentarium, this is really important so that we give time for the drug to act first and give the label as no response. Another critical thing is angle closure. So whenever we deal with any glaucoma patient, it's really critical to remove the angle closure out of weak patient first. Then when we direct the patient, sometimes we can pick up pseudo exfoliation. So this is important. And we can always ask for steroid use and also old trauma. Steroids in all forms, skin ointment, nasal spray, everything is critical. And it's better to check IOP with the same instrument, not eye care ones and GAT ones and Perkin ones. If possible, we also have to check the instrument calibration. In selected cases, when we're not identifying anything, it is better to do DVT in some situations. So we have started a drop. So what do we do now? So there is no response. Do we switch or add? If there is no response, it is better to switch an agent before adding an agent, because when we add an agent, we don't know if the first drug is not working or the second drug is not working. So intra-class switch is possible only with prostaglandins. So if we have started on latanoprost and there is no response, we can go for bimetoprost. But this is not necessary with other drugs like harmonic kinase inhibitors. So when we have started dorzolamide and there is no response, it's not necessary to switch to brinzolamide. When we say no response, it is just less than 20 to 30% reduction from the baseline. So this is not exact. We can have an approximate value. So if we have a response, but the response is inadequate, then we go and add AGM. So it is better to give friendly combinations and dosing steroid. Again, the quality of life matters. So this is why pilocarpine is in the last choice, because we have to give it 3 to 4 times a day, and it's not easy to put drops 3 times a day every day. And it's always better to combine drugs with different mechanism of actions. So like a drug which promotes outflow plus a drug which decreases inflow. So this is not always possible, but when possible, we can always combine a prostaglandin with the Tnoa. So adherence is really critical. So this is one study which gave free drops, a dosing aid, instructions, and once daily use of Trabeculectomy and electronic monitoring of adherence. In spite of all this, about 45% of the patients took fewer than 75% of the prescribed drugs. This is really high in spite of extensive monitoring. This is not possible in our clinic. So adherence is really important. So this is my algorithm that I follow. So in primary glaucomas, I would always start a prostaglandin. If it's not possible and there are some cost issues, it's better to start timolol. So monotherapy if the disease allows. And in secondary glaucomas, this is not always possible. So we can start maximal medical therapy. So it's better to review the patient at least 2 to 3 weeks. So in between, if you're afraid of the high pressure spikes and vascular events, we can always give Dimox cover. If the response is good, we can continue and plan investigations like fields and OCT whenever it is needed. If the response is good, we can continue the same. If the response is okay, but it's inadequate, then I would add alpha agonist. Alpha agonist than carbonic anhydrase, because this, in addition to the inflow decreasing action, also has some promoting of outflow. So when given a choice, alpha agonist first, then carbonic anhydrase. If there is no response, then we can switch before adding AGM. The further AGM switch is based on the side effects and the cost issues that the patient experience. So and further adjustments are again based on the side effects. So if the patient is intolerant to a particular drug like bromosid energy or intense hyperemia with prostaglandins, then we can always change. And contraindications, like the patient develops asthma, so then we can't give timolol. So then we can always change the medications based on the systemic conditions that they have. The cost is again critical. SLT, if available, we can always go for it because it takes the drug allergy equation, the cost equation out of it. And we have to clearly understand that there are no symptoms of glaucoma that therapy improves. We are only introducing more symptoms to a patient who has no symptoms of glaucoma. So we need, so the patients need positive reinforcement to continue therapy. It is better to pre-warn the patient regarding certain side effects like irritation, hyperemia, so that they don't discontinue the therapy. Then coming to the controversy of generics versus branded. So there is a concept of essential similarity. So we have three major formulations like branded ones. These are the ones that actually go through the rigorous trials and get approved for market use. Then we have the branded generics, and then we have the generics. So generics are accepted for market use if there is only a 5 to 10% difference of the active ingredient from the branded ones. So, but this is not only critical. We also have a lot of inactive ingredients like the buffers, excipients, and preservatives that make a difference. So the drop size, the pH, osmolarity, particulate matter always differ between the generics and branded. Also, the squeezability of the bottle affect compliances. So what do we give? Generics or branded? Generics always, if possible, but the cost is one rate limiting factor because the patient has to take for his lifetime, and it's not always possible to offer such a costly drop. So regarding the efficacy, the reports are variable in literature. Some say branded is always better than, some say branded is better than generics, but one issue is always with the side effects. So again, these reports are variable. Some say generics side effects are more than branded. So this we have to really see and decide based on our patient's response. So we have to realize ocular surface is real. Ocular surface disease is real. So this is one of our patients who had intense irritation. So when we just retracted the conjunctiva, this is what we saw. So intense conjunctival concretions because of the dry eye disease. So this is another neovascular glaucoma who developed extensive corneal vascularization from the ocular surface disease. So when possible, it's always better to use preservative-free combinations. But again, it's not possible with all medications, especially when you're going to add 2 or 3 drugs. So, and again, cost is one rate limiting factor. So this was one of our patients. He was on 4 classes of anti-glaucoma medications. So this was the conjunctiva pre-op. So we tried to optimize the conjunctiva, gave him short steroids with Dimox, but this is 1 year post-op. And you can see the hyperemia still persisting and the bleb has failed. So this is a real issue. So conjunctiva is important not only for the cosmetic purpose, but also decides the success of our trial. So we all know prostaglandin is the best drug that is available, but we have to consider prostaglandin associated periorbitopathy too. So these are 2 patients. This patient is 80 plus, and he's only 40 years. So these patients have been on bimetoprost for quite some years. So this is what we call as DUCE, deepening of upper eyelid sulcus. So this is happening because of the selective destruction of the orbital fat. So this is more with the bimetoprost than the latanoprost. So when we are starting bimetoprost, especially in young patients, it's really important that they understand that there is a side effect like this happening. This is not only for the cosmetic issue because during surgery also we'll have issues with the traction suture, making the flap. Phaco can be okay when we do twin side phaco, but post-op bleb management and doing suture laces is really difficult with such a deep socket. So this is a new drug that we have, Netarsudil. Regarding the efficacy, it's quite good. We are happy with the IOP control that it gives, but this is what these are 3 different patients who have experienced different levels of corneal edema because of Netarsudil. The reason is unclear, but it's reversible when we stop the drug. This is reticular corneal edema because of Netarsudil. Another important issue with Netarsudil is the intense conjunctival hyperemia. This we pre-warn the patient sometimes, but this patient was actually posted for phacotrabeculectomy. When he complained of redness, when I retracted the conjunctiva, this is what he saw. This is proper subconjunctival hemorrhage from Netarsudil. So this is not an ideal situation to go with TRAB. So we stopped the Netarsudil drop, gave him FML and lubricants, and this is how their stage resolved. So it is really important to optimize the conjunctiva before surgery when we're starting the patient on so many medications. So, and when we start medications, we cannot avoid the side effects, but we can at least reduce the side effects. We can teach the patients how to instill the drops. So this is especially common with bromoretin, so blepharoconjunctivitis. So it is critical that the drop goes only to the conjunctival sac and does not touch any of the surrounding periorbital skin. So this is one more patient who experienced this side effect because of bromoretin. And also it's critical to teach punctal occlusion to the patients, especially important to reduce the systemic effect and also in pregnant patients. So we can teach them to put the drop, close the eyes for 2 minutes, do punctal occlusion, and at least give 5 minutes interval before starting the next drop. So I would like to stop with this patient. So this was one primary open angle glaucoma patient who experienced recurrent disc hemorrhage. IOP was stable, fields showed mild progression, but when I asked him to show how he was applying his drop, this is what he did. He has a bag and he carries his mirror. So this is how he applies his drop. So this is really critical actually because we don't teach the patients how to apply the drops properly. So this is important because glaucoma is a chronic disease and the patients have to adhere to the medications. So we have to teach the patient regarding the therapy and the side effects before going on to surgery. Thank you.
Thank you, Prasanna. I think we have had some wonderful introductory talks on diagnostics as well as initiation of treatment. And I now request Dr. Parivardhini, who is a consultant of Glaucoma Shrunken to share her thoughts on initiation of surgical management. Dr. Pari, can you share your screen?
Prasanna, well done.
Yes, yes.
Well
Thank
done.
you, sir. Thank you, sir.
We all require encouragement. Thank you, Mr. President.
Pleasure.
Yeah, Dr. Parivardhini.
Yeah, yes, sir. Yes, sir.
Yeah. Okay, thank you. Yes.
Thank you.
Satyan, are you back? Is your network stable now?
Yeah. Can you hear now?
Yes, Satyan. Yes.
Okay.
Sir,
Thank you, Dr. Parivardhini.
Yes, Parivardhini, you can start.
Good morning, sir. At the outset, I would like to thank the organizers of Tnoa Connect for giving me this opportunity. I'll be speaking about the glaucoma chop, the right surgical strike. I'll restrict my talk to trabeculectomy and management of its complications. As we all know, trabeculectomy is a gold standard of glaucoma surgery. It is the most frequently performed glaucoma surgery. Here we create a fistula at the limbus, which allows direct communication between the anterior chamber and the subconjunctival space. So as important as a meticulous trabeculectomy is considering the pre-op condition of the eye. We have to treat meibomitis or blepharitis if the patient has preoperatively, and look at the conjunctiva if the patient has any allergy due to anti-glaucoma medications use. If the patient has hyperemia and allergy, the offending anti-glaucoma medication has to be stopped and Diamox is given to control the pressure. And also giving low dose topical steroids for a short time will help in reducing the hyperemia and reducing the bleeding intraoperatively. The intraocular pressure should be importantly brought under control before we open the eye to prevent the risk of choroidal hemorrhage on table. So this is a short video showing the steps of trabeculectomy. Superior rectus suture or corneal traction suture can be taken for adequate exposure of the surgical site. A phonics based or a limbus based conjunctival flap can be used. But most often nowadays we have shifted over to a phonics-based conjunctival opening, which gives a more posteriorly directed bleb. The bleeders are cauterized. Then mitomycin C spoked sponges around 0.2 to 0.4 milligram per ml concentration for 1 to 2 minutes or 3 minutes, depending on whether it is a primary surgery or a resurgery, is placed. And then after the sponges are removed, it is adequately washed with balanced salt solution. Then a partial thickness scleral flap is created. Here a triangular flap is fashioned. Around half to two-third thickness of the scleral flap is created, making sure that the limbus do not reach till the limbus, so that the direction of the flow is more posterior. And we have to cut the intervening fibers and not the bed so that shelving can be prevented. The paracentesis is done before we do a trabeculectomy stoma. The stoma here is created using Kelly's Desmet sponge. Usually 2 to 3 punches will be enough to create an adequate opening. Then peripheral iridectomy is done. This will prevent postoperative pupillary blocks or the iris plugging the stoma. Then the flap here is sutured with fixed suture and releasable suture. Releasable suture will help us in titrating the intraocular pressure in the postoperative period. An apical releasable suture again will help us in giving a more posteriorly directed bleb. Then the conjunctiva is sutured. Here an edge purse string suture is being fashioned, but any type of conjunctival suturing which we are comfortable with, which will give a watertight closure, is what is more important. Horizontal mattress suture can also be taken to prevent the receding of the conjunctiva in the postoperative period, especially in young patients. In young patients with high myopia or very high intraocular pressure, there is a risk of choroidal hemorrhage occurring in intraoperatively itself. So usually the inciting event is hypotony. So if the duration of hypotony is prevented, the choroidal hemorrhage can be prevented. So this can be done by the use of anterior chamber maintainer. This is a 16-year-old girl with advanced primary open angle glaucoma with high myopia. So for her, I used a 25 gauge trocar, which is used in VR surgeries. So this trocar will snugly fit to the port and there will be no leakage, so that there is no hypotony during the surgery. So another important thing is to take pre-placed sutures in such eyes, so that immediately after creating the stoma, the flap is sutured and the hypotony doesn't set in. So postoperatively, we'll manage them with giving topical steroids, which will decrease the conjunctival scarring and increase the success rate. Topical antibiotics are given depending on if they are one-night patients or if the hygiene is compromised. Cycloplegics are given in angle closure eyes for the first 2 or 3 weeks. So glaucoma surgeries, as we all know, are not without complications, even in the best of hands. So if we are able to recognize it at the early stage and giving the management, will go a long way in preserving the blood function in these eyes. So intraoperatively, if at all there is a conjunctival buttonhole or a tear, if it's in the early stage, we can create a new one or move the scleral flap site away from the buttonhole. The later stages, we'll have to directly repair them with a 9-0 or a 10-0 nylon suture. So even if it's a large tear and we are not able to close it watertight, putting a large diameter BCL at the end of the surgery will help in re-epithelializing the conjunctival wound. And most often, if we use non-tooth forceps, this buttonholing, all these things can be prevented. A scleral flap tear can also occur, which can be directly sutured. And sometimes we can end up with these thin scleral flaps if the flaps have been fashioned in a wrong manner, or we have overzealously cauterized the scleral bed too much. So in these cases, we can transpose adjacent from the sclera, we can take a partial thickness scleral flap and close it over it. However, if it is still not able to close it, we can take a partial thickness scleral flap. A donor scleral flap can also be used to close this. As I also mentioned, the suprachoroidal hemorrhage, though a rare complication, can occur, which is a dreaded complication. We usually identify it with the loss of red reflex and mound, which is seen. Immediately, the scleral flap has to be closed, the surgery has to be stopped, and IV mannitol has to be given. Post-operatively, all would wish for seeing a good diffuse microcystic avascular bleb with deep anterior chamber with minimal inflammation. But most often, these are not the scenarios we come across. We do come across few eyes which have such dense subconjunctival hemorrhage, which can cause early fibrosis of the bleb. So increasing the topical steroid usage and giving serial subconjunctival 5-FU injections will help in reducing the subconjunctival hemorrhage. So if the hyphema, minimal hyphemas usually will clear up by themselves, but if they are persisting for more than 5 days, they can cause ultimately failure of the bleb. So we take them up for AC wash to clear up the debris. And overfiltration is again a common condition which can be seen if we have not sutured the scleral flap adequately, or if we have a large stoma with minimal overlap. Or in the postoperative period, if we have removed the sutures early, or if we have removed more than one suture at a time. Patient has a cough or sneezing or any straining, this can again lead to overfiltration. So first thing is to rule out choroidals, give them cycloplegics. A pressure torpedo patch helps in formation of the anterior chamber. So, however, if the conservative measures fail, then we might have to take the patient for the operation theatre to form the anterior chamber with Helon or with C3F8 gases. A wound leak is another common complication seen in the early postoperative period. We can see a flat bleb with low intraocular pressure, where the intraocular pressure is not correlating to the bleb appearance. Or sometimes if the leak is large, then we can also see a shallow anterior chamber. This can be identified by a simple Seidels test. When we stain with the fluorescent stain, we can see the dilution of the dye by which we can identify this. Immediately looking at the slit lamp with the blue filter will identify where the leak is, whether it is a point leak or a sheet leak from the conjunctival edge. Usually conservative measures are enough to heal the leaks with a pressure patch, cycloplegics, even a large bandage contact lens, which can be used almost for 5 to 7 days for reepithelialization and then removal. However, if they don't work, if the leak is still not healing, if the conjunctiva has receded over the scleral flap, if we have a shallow anterior chamber, we might have to take for suturing. A shallow AC with raised intraocular pressure occurs due to pupillary block or choroidal hemorrhage. A pupillary block, a YAG PI has to be done, but in both these conditions, intensive steroids has to be given, cycloplegics have to be given. In case of choroidal hemorrhage, a serial ultrasound has to be done to assess clot lysis. After the adequate clot lysis has occurred, we have to plan a surgical drainage. So an encysted bleb is again a common condition where we look, where we see a very angry looking dome-shaped thick walled bleb with elevated intraocular pressure. The onset is usually 1 to 8 weeks. And we can see in the imaging that with this encysted bleb, there are no formation of microcysts which are seen with the functional bleb. Conservative management with aqueous suppressants will reduce the pressure on the cyst wall, which will increase its permeability and cause flow of the aqueous. Use of topical steroids are also known to be helpful. But if the conservative treatment doesn't help, then we have to resort to needling. This can be done in the operation theatre or even in the OPD settings with the use of mitomycin C or 5-fluorouracil. Bent 27 gauge needle is used, and the entry is made away from the bleb area with the ZEC technique, first in the conjunctiva and then into the tenons. And once we break the septa, we can see that the bleb formation has occurred. Another dreaded complication like aqueous misdirection can occur in the postoperative period in angle closure eyes. The inciting event is usually overfiltration or a wound leak. That is why in angle closure eyes, we always make sure that we close the flap tightly so that this overfiltration doesn't occur. We can identify it with axial myopia, and we can see with the uveum that there is anteriorly rotated ciliary processes. Management consists of cycloplegics and intensive steroids, and the anterior hyalodotomy done through the pre-existing surgical PI will help in forming the anterior chamber. The conservative measures don't work out, then we go for vitrectomy, hyalodotomy, zoilodohyalodectomy. What is the time, sir? Have I?
One more minute. Yeah.
1 more minute.
important. So chronic hypotony in the late postoperative period is again a common finding with the use of mitomycin C. It can be because of overfiltering bleb or because of bleb leaks. Chronic hypotony, though many management options are there, we usually go ahead with an autologous blood injection plus minus compression sutures. So this is a short video showing a young patient with overfiltering bleb who had low pressures for a long time. So autologous, the blood is collected from her antecubital vein and it is injected immediately after collection with a 30 gauge needle. And then with the 10-0 nylon, a partial thickness corneal incision is taken in front of the blood, and then the compression sutures are done. Bleb leaks are managed with conjunctival advancement or with conjunctival patch graft. So I would conclude that meticulous attention to the detail during surgery is very important, and a careful post-operative examination for prompt recognition of complications with appropriate management will go a long way in making these blebs survive. Thank you.
Thank you, Dr. Parivadini. I hope I am pronouncing your name right now, Dr. Parivadini.
Parivadini, sir.
Parivadini. Okay, okay. Sorry. Okay. Parivadini. Okay. Yeah, with that, we will go move to the last topic of the day, Dr. Devendra. Dr. Devendra has been assisting Dr. Ramkrishnan for over a decade and an innovative and excellent surgeon. I request him to speak on the role of LPI versus lens extraction and angle closure disease.
Am I audible, sir?
Yes, Devendra.
Yes.
Good afternoon, everybody. I would like to thank Dr. R.K. sir, Krishna sir, Mohan Rajan sir, and Satyan sir for giving this opportunity. So today I am going to talk about laser peripheral iridotomy versus lens extraction and primary angle closure disease. Though this topic is a little controversial, doing a YAG-PI or lens extraction and the angle closure disease. So I will put forward some of the evidence, what we have and what's the current situation in our country and what we should carry forward. So as all we know, the primary angle closure disease is a blinding disease, is one of the major cause of the irreversible blindness. If we look into the present scenario, there's almost 20 million people have the angle closure disease. By the 2040, there will be 34 million, and out of them, 5.3 million are blind. Look into the Indian scenario, there's almost prevalence is 0.7 to 1.1% of age more than 40 years. If you look into the real numbers, India have the 21 million have the primary angle closure suspect, 4 million primary angle closure, and 2.4 million have the primary angle closure. Glaucoma. So look, the study done by Seota also, almost half of the glaucoma presenting at the hospital setting are having the angle closure glaucoma. With the advent of evolution of anti-segment OCT and UBM, the understanding of disease pathology keep improving. There are the multiple factors involved in the pathogenesis of the angle closure glaucoma, like some genetic factor, environmental factor, and anatomical factors. So these are the various mechanisms of angle closure glaucoma, like a pupillary block, lens-induced glaucoma, aqueous obstruction, and pupillary block. So this is the current classification by ICGO, where the primary angle closure disease is classified as a PACS, in which the iridotopic contact more than 180 degree with absence of any glaucomatous damage on the disc and the absence of elevated IOP. While in the primary angle closure, there is the iridotopic contact more than 180, either they have the elevated IOP or they have the posterior synetia. While primary angle closure glaucoma classified with the first two, either having the iridotopic contact, having passed, or having the optic nerve head damage. While the acute angle closure crisis is defined as a acute angle closure glaucoma, as all we know. So this is the disease continuum, the PAC converted the PAC to the PACD. The study done by Ravi Thomas et al. Showed the almost 22% of PACS converted to the PAC over a period of 5 years, while around 30% PAC converted to the PACD. So these are the current treatment options available for the primary angle closure disease. I will focus my talk on the LPI and lens extraction. As all we know, peripheral iridotomy is a standard approach for treating the PACS, PAC, and PACD with or without anti-glaucoma medication. As the YAG reduces the pressure difference between the anterior and posterior chamber, it relieves the pupillary block and widens the open angle. But some of the angle is not open even after the YAG because they have a different mechanism of action. Probably they have the plateau iris, thick iris, anti-insertional lens, and having the large lens. So what the YAG is going to do, just relieve the one magnitude of the angle, relieve the one magnitude of angle closure glaucoma. So there's a question mark: are we doing so many YAG? And how we should manage the asymptomatic PACS? To answer this question, several studies have been done to assess the risk of primary angle closure suspect developing into the acute angle glaucoma. And the study find out that only few patients over a period of time develop the acute attack. To further study, to further prove it, the Singapore National Eye Institute had done the study. It's called the asymptomatic narrow angle laser hydrotomy study, analysis study. In this study, they recruited 476 subjects, age more than 50 years, having the bilateral hydrotomical contract, and they randomized one eye for hydrotomy and other eye for the no intervention. And the progression was defined in the presence of developing the peripheral anonychia, increased IOP, or acute attack. And they find out at the end of 5 years, the 10% progression was seen in the no intervention group in compared to the hydrotomy group. And it shows that the no intervention increased the risk of progression twice to the prophylactic LPI in the PACS. Though this study was done in the hospital setting, so what the patient presenting to hospital, they are having the PACS. To answer further, the Johnson angle closure study has been done in China, and this is a large study in which the 889 patients were participated, and the patient having the bilateral asymptomatic narrow angle, age more than 50 years, and the patient who having the no symptom, and their eye has been randomized into one eye into the YAG group, and contralateral eye, there is a no intervention was done. And primary endpoint was defined, IOP more than 24 mmHg at the 2 separate occasions, development of the posterior synechia more than 1 quadrant, and there's an acute attack of the angle closure. At the end of 6 years, they find out only 99 progress into the LPA group versus 36 into the no treatment group. So this study shows the LPI is good, a safer option, but the rate of developing any angle closure endpoint was much lower than expected in primary angle closure suspect, less than 1% in a year. And only 1 in 20 untreated eye of primary angle closure suspect developed the primary angle closure at 6 years. Therefore, despite the safety and preventive value, widespread YAG is not recommended for the larger population. So what we learned from this ZAP trial, the PACS really having the low risk. Either all patients should go for the LPI or not, we have to think it. We have to assess the risk and benefit of the LPI to patient, then go for it. But before extrapolating this ZAP trial result, we have to keep in mind these all the patients in this study are Chinese, and they are the quite young population. So which patients should go for the LPI? The patient who have a symptomatic PACs, either having the headache, broache, or having the color red nose, or the PACs patient who having the some retinal pathology, need required dilatation, and the PACs patient who have poor access to the healthcare system and they don't come for the regular follow-up, and the PACs patient who have the family history of glaucoma, and someone is blind due to the primary angle closure disease, need the LPI. Apart from that, the fellow eye of the primary angle closure, glaucoma, and acute patient must go for the LPI. Now coming to the second part of my talk, this is angle ARP versus resection, primary angle closure and primary angle closure glaucoma. So as all we know, there is a growing body of evidence suggests that external lens play a major role in the pathogenesis of angle closure glaucoma. Eye with angle closure glaucoma has significant anatomic difference from the normal eye, and the Hassi et al. Study has shown after the phacoemulsification and PCL implantation, anterior chamber depth and angle width in angle closure eye approximately similar to the POAD eyes. This study done by Lewis et al. Has shown that lens restriction in the acute primary angle closure not only deepen the AC and open the angles, but also decrease the diagonal variation and improve the outflow facility. There are various studies have there are various studies have done to see the effect of ciliary lens extraction in PAC and the PACG cases. And the various studies have shown and the patient who underwent the ciliary lens extraction has the good IOP control in compared to the TREP versus LPI. So in this study, what we suggest, we can go for ciliary lens extraction in PAC and PACG eyes. To see this large multi-centric trial done in the worldwide is early lens extraction for treatment of primary angular glaucoma is called as an EAGLE trial. It's a multi-centric worldwide run trial. There's a 490 phakic patients were recruited, age more than 50 years, and they are having the either PAC plus having the IOP more than 31 mmHg, or they are having the PACG cases. So what the patients were excluded, but the symptomatic cataract and the advanced glaucoma or having the previous acute attack. This study randomized the patient into two groups. First group underwent the lens extraction plus PCI implantation in 2.4 eyes, while the other group just LPI was done in 2.5 eyes. So at the end of 5 years, they showed the intraocular pressure is 1.1 mmHg lower than the ciliary lens extraction in compared to the LPI group. Apart from that, the subset of the patient in the, especially in UK, some part of the UK, they have done the study, they find out the quality of life is much better in the lens extraction group in compared to LPI. And they showed it's a less effective. So what the EAGLE trial concluded, the ciliary lens extraction was superior than LPI in terms of patient reported health, IOP control, and need of anti-glaucoma medication, and it's a cost effective. So this result indicates that ciliary lens extraction should be considered as the initial treatment for PAC and PACG with increased IOP. However, there's certain issue with EAGLE's trial. Whatever the lens they remove in this trial, all not on the clear lenses, and what are the cases they include in the PACG, they all in the milder PACG form. And all the surgery had been done by the very experienced surgeon. So what we learned from the EAGLE's trial, there's a definitely trend toward the early lens extraction, though it's an aggressive approach, but we should discuss all the risk and benefit of the lens extraction and LPI to the patient and give option to patient and take the decision. And try not to do the ciliary lens extraction. So the argument in favor of the lens extraction, good IOP control in PAC and PACG eyes is cost effective and improve the quality of life, reduce the number of visits, better safety profile, and reduce the need of medication and decrease the incidence of pus formation. But argument against the lens extraction, the complication of surgery in compared to LPI, the intraocular complication and difficulty in surgery in angle closure eyes, there is a risk of endophthalmitis, and there is always which a financial issue in developing country like India to going for the cataract surgery. So now coming to the last part, the phaco versus LPI for acute angle closure glaucoma. So Ting et al. Has done the study, and he find out after doing the LPI, most of the acute attack has been resolved, but out of 58% required medical therapy and 32% required the trabeculectomy over period of time. So this literature showed the two study, and they find out doing phaco and acute angle closure glaucoma reduce the IOP over period of time. So these two studies, one done by the Lam et al. In Hong Kong and Hussain done in the Singapore. And this both study, they recruited the acute attack patients, and one arm they went for phacoemulsification, other arm went for the LPI. And they showed this phaco group has the good IOP control, and number of the medication required in the LPI group was 50% versus 3.3% into the phaco group. Similar result was shown in Singapore study. Let's find out the, can I have 1 minute more, sir?
Yes, please go ahead.
Yeah. So the Singapore study has shown the good IOP control, and the LPI group again have the more anti-glaucoma medication. So just to summarize this study, what we learned, this is definitely this is a phacoemulsification reduce IOP over period of time. But there is a no clear consensus when we have to do the ciliary lens extraction, either within 1 week of medically controlled acute attack or at least 1 month after the amendment of acute attack. So just to keep in mind, this is always challenging to do the phaco in acute angle glaucoma cases because of big lenses and shallow AC. There's a poor visualization of posterior capsule, risk of PCR and endothelial damage and endothelial decompensation. And this surgery has to be done by the experienced surgeon. So just to summarize, newer approach, including early lens mover, are gaining popularity because of their potential long-term success in IP control. Decision to do clear lens extraction must be individualized, bearing the benefit and risk of complication associated with intraocular surgery. PACD is not a single disease, rather it's a continuum of disease. So thus each patient is unique in terms of the disease. The management profile has to be tailored. Thank you.
Thank you, David. I think the summary slide was great. I think it just summarizes whatever is the thought on management of ACG, LPI versus lens extraction. We have had excellent talks from all the 7 speakers. I would like to congratulate and thank all of them for the time they've invested. Do we have any questions from the audience?
Audience, I don't. Chat box.
They can send the questions through chat box. No? Do we have that, or should we go in for a panel discussion?
No. I think Satyan coordinate with Manju or Sai, and they'll be we'll be getting the questions on the chat box. So
any questions from the panel, Dr. Mohan?
Yeah, I have a question for the first speaker, Dr. Sweta, because it's always when you have high myopia or a tilted disc, very difficult to find out whether it's glaucomatous or not. So what are the tips and tricks to find out high myopia? The patient has got myopic macular degeneration, would not know whether the pallor is secondary to that or secondary to the glaucoma also. So how do you know? How do you diagnose that, and how do you also gauge the progression?
It's really tricky to identify glaucoma seeing just the fundus in a myopic patient. This is where we need actually the investigations part for the glaucoma. So if you have an OCT, especially the spectralis OCT, if you do for the myopic patients, it beautifully gives us the Brooks membrane opening, and you can see what exactly the posterior pole and the ganglion cells are in that cases. So in myopic patients with a tilted disc, more than the RNFL and the disc, we will more concentrate on the ganglion cell pattern. So if you see the donut pattern, you're sure that it is a normal case. But if you have the early glaucoma damage or the medium damage, it will be beautifully seen in the GCL pattern. So you can even see the progression with the help of this OCT, spectralis OCT, that is more useful than going in for a fundus photo in myopic patients. That is what I have.
And excuse me, I would like to just give a few comments.
Yeah.
See, we are all the time looking at imagery. Like you can have a Caucasian, you can have an African, and you can have a Gurkha. They're all 3 soldiers. They're meant to pull a trigger. So function is the same. Check the visual function. You have a high myope, please put a contact lens. Do a good visual field, because function is what the patient wants. And also you must remember, when you're taking the diameter in the OCT, it's a standard diameter, so you can miss it. So if you have a large disc, you can miss it. If you have you can have a red disease in a completely normal fundus. I mean, I'm just puzzling you a little bit, but it's just that, as a part of discussion, we always look at function also. Okay.
I agree with Rangaraj. Not function also, but in eyes like myopes, when it's very difficult to diagnose from the structural aspect and OCT, it is better to depend only on functional impairment, like on visual fields, and also take into consideration other risk factors like cornea-corrected intraocular pressure, family history of glaucoma and such. At the end of it, if you have a doubt, please treat. Because all myopes are glaucoma unless otherwise proved.
That's a good message.
A good message.
Yeah, but I feel the OCT gives definitely a much better measure than the functional test, because it's quite difficult to get a good visual fields in myopes. But with the spectralis, we can definitely look at the BMO and the GCL pattern, it's quite often that we can really pick up the glaucomatous changes in the myopic eyes. Then
point well taken, Satyan. Point well taken. I think we need everything in place, try to corroborate as much as possible, and then take a decision. Yes. Okay.
Another thing, also generally, also we have to look at the neural rim color also. That's sometimes we have to the pallor is another thing which we have to. Suppose the pallor exceeds the limit of the cup, then it's definitely it's not we have seen most of the time, especially the other causes like nutritional amblyopia or some of the pituitary tumors. Some of the pituitary tumors also may, a long-standing tumor may mimic glaucomatous cup. So in that case also, you have to be a little more careful and examine the optics, and also you have to go by the fields and other things.
Satyan and Sweta, tell us more about fundus photography. Recently, probably under influence from Satyan, I am also depending more and more fundus photos for better diagnosis of early glaucoma, especially.
100%. I'm always been excited with these fundus photographs, especially when you have the connectivity to your desktop in your consultation room. Just having a fundus photography taken and then you have a printout in your hand, I feel it is probably even less impactful than you having a 90-day examination done. You have to have the software installed in your desktop and then open up your fundus photography. It is one of the easiest thing that you can have is just connect your fundus photo machine through the LAN connectivity in your desktop. That is one of the most easiest.
What software is it?
Sir, every company gives their software, sir. Every company, the fundus photo, the machine, the company gives you the software to install in your desktop. And it is free also. It's not, they charge you. So it is,
I think
you can magnify.
It's free of charge.
Which one? Sorry?
If it's IDEN, it's free of charge. The rest of them charge. I just have one more point to make on fundus photo, especially the optic disc. I find that my yield for picking up splinter hemorrhages has improved dramatically because I take a fundus photo. Because if you have a tiny little splinter heme, even if I use my Keeler with high mag, I can miss it. But when I take a fundus photo, I don't miss it. So I started to pick up more of these splinter hemes when I started to take a photograph, which actually brought me to the point that I searched the literature and found that your uptake of finding these small little splinter hemorrhages, especially in the red free, is very high. And then you can always go back clinically and see it. I find that when I go back, I can see it, but which I didn't miss it. And it sometimes looks just like a small blood vessel sitting next to the rim. That's my
the NFL defect also is more clear with the fundus photo than with the
perfect. Yes, sir.
Precisely.
Yeah. And also, Dr. Sweta mentioned about the RNF defect, which may not be due to glaucoma. It's true. Most of the time, a normal physiological split, what they call is common. It may make a retinal nerve defect, but the width will be almost uniform throughout the course. That thing.
Sir, okay, sir, just to mention the RNFL changes, what we have got the surprise is the inferior or superior RNFL defects without the notch from the disc margin seems to be more with the Alzheimer's, Parkinson's, and the thyroid disease, which we always been kind of missing it as a glaucomatous changes.
Absolutely, Satyan. Actually, after you started mentioning it, I also seem to have realized it. Thank you.
Yeah. And about 40% of the people, above 46% of the people above the age of 40 have a vitamin B12 deficiency is very often seen, which we will never be able to pick up in our 3 or 4 people. So just taking we have made it as a routine for every patient. Now we feel without, if you're, like without fundus photography, if you see any patients, I feel like probably we are missing so many diagnoses like diabetic retinopathy, B12 deficiency, thyroid diseases, Alzheimer's, Parkinson's, and of course the glaucoma. So without the fundus, because the fundus photography gives an evidence in future, even somebody else sees that, they will also know that how much of the cupping was there, how much is the progression that has happened, everything can be in detail. And also a great teaching tool. Well, so I feel fundus photography with access in your desktop system is the way to go in the future.
Geeta from Chennai has two questions. I think the one on role of OCT in high myopia probably has been addressed. She wants to know CCT is to be considered or added to decide baseline IOP or to consider as an independent risk factor. What would be the panelist response to this? The role of CCT in glaucoma management, in short.
Yeah, the role of CCT actually is a little funny game, truthfully speaking, because people started telling because of the high CCT, the IOP has shown up as just abnormal. But what we need to understand is the patient definitely has a higher intraocular pressures. But only thing is, as the patient has a higher CCT values, the possibility of having a higher risk for damage is lesser in comparison to those who have a lesser corneal thickness values. It does not mean the patient is not having glaucoma. Patient has a ocular hypertension to an extent, we can say like that. But when the IOP is higher, the possibility of having the progression, the risk of progression in comparison to the other patients are lesser. That's the information that we need to take it.
I think we are moving more and more towards risk stratification based on CCT, as Satyan has mentioned. And of course, those with higher corneal thickness are definitely, we are overestimating intraocular pressure to some extent. And those with thinner, we are underestimating. That we need to remember. But as Satyan said, if the corneas are thicker, the progression, the risk of progression is lesser and vice versa. To that extent, CCT is a must in terms of prognosticating, stratifying risk and following up. I think it's essential that we have an idea of the corneal thickness in every patient.
Only thing is, once there is an established disease, the CCT has a very less role to play. That we must understand. Probably it is more helpful in ocular hypertensives or an NTG patients, whether they're in NTG or POAG. Those kind of areas, the CCT is quite helpful. But when you have a very established disease, it's better not to have your CCT in the mind all the time and then keep thinking about your target pressures. So we must understand that. For target pressures, we have other parameters. The European Glaucoma Society guidelines, you can just look at it. Of course, CCT is one of the things, but it is not the major one once you have the established disease. Regarding the medications usage, we all know that the prostaglandins, of course, most of us do prescribe the prostaglandins. The timolol, of course, all of us do use timolol, but it has become a second-line drug rather than the first-line choice. The simple reason is it's a once-a-day dosing. The ocular and the systemic side effects are much lesser. So all those things are very well established. Only question is now whether it is a generic versus the originator. So what is your take on the generics versus original molecule? How do you really go in for it?
Let's start with Prasanna, who talked on the topic, and then go on for others. Prasanna?
Sir, the cost is a major barrier. So if the patient can afford, it's always better to start a branded one. But continuing the same medication is one rate limiting thing, because if you're going to add medication and if you're going to give another branded one to the same patient, they can afford is one question. Because they have to use it for quite some time.
Any other senior member of the panel? Ramkrishnan, Mohan, Rangaraj. Rangaraj, what is your first choice?
Actually, my first choice would be, I would go in for convenience of dosage, which means I'm going to go for a prostaglandin and take it from there. And in my practice, I think they can afford it. So they go ahead with that. So I would go ahead with the convenience of dosage, because this is something which is going to be prolonged, and time it with an event. So if I get adequate control with that, then I mean, we are happy with that.
Do you always go with the original branded ones
just
or branded?
the question
The
is
original molecule, unless
yeah,
otherwise,
original molecule.
yeah, unless otherwise the patient expressly says that they can't afford, then we take it in writing that they're going in for generic.
Any other thoughts?
Shankar Nethrali
I'll just give my.
Is there any difference between the two? I'm asking.
Yes, Shankar Nethrali has done some studies on that, and they have shown that definitely the efficacy is a little less in generics. But they may have been generics of the past, but probably now the quality is good. So we don't have a present study on that. So until then, we give the benefit of doubt.
Yeah, I'll just want to add a point in this, like that Rangaraj was mentioning. Arun study has been done quite a long time back, but now the generics, definitely there are quite a good number of generics. So in case, of course, the originator is always, we think it is a good one. Nothing wrong in that saying that. But the generics molecules, when you are starting on medication, the first time I'm saying, if you're really concerned about the cost when we are starting on the generics, we can always look at how much is the IOP drop the patient has. Is that the molecule as such is working for the patient? We can always start and see if it is working, and if it is adequately controlling, there is nothing wrong in continuing with the generics as such. But if you feel that the medication is completely not working, even if you go for the original molecule, it still may not work. So I feel many times, I usually start with the generics, and if it works, adequately controlling or getting the target IOP, I just continue as it is. If it is controlling and it is still not adequately controlling, say for example, probably a millimeter or two is additionally required, then I'll go for the original molecule. So that is one way how we can really reduce the cost of the medication. So when we are talking about the cost, there are so many other things comes in, but I'm not going for that bigger topic now. But that could be one of the ways that we can think about.
This
and
is what I subscribe
questions
to.
on that.
Yes, yeah.
Yeah,
I do subscribe to this.
Sorry, RK sir, or
Yes,
any others?
I agree with Satyan. But in most of the in our practice, no. So I mainly because the difference what I observed in clinical day-to-day practice, is not much of difference in efficacy of generic branded drugs. So it depends upon the patient affordability and all these things. I will try to generic or branded medications. Yes.
Yeah. So I'll just go to the next area of, we all practice glaucoma, mostly still based on the intraocular pressure levels. But how many of us really categorize the disease into mild, moderate, severe, or advanced? Because most of the time it is just how much of an intraocular pressure that we can reduce the moment we see the patient with the glaucoma. And there is always a wrong concept, or I wouldn't say wrong concept. There is a misconcept of looking at the disc and saying that the patient has 70% damage or 80% damage or 90% damage. Because the cup does not say how much the patient has a damage. Unless you do the visual fields or a VOCT, you can never say how much of the damage the patient has. 80% appearance of the cup, the patient may have a 0 damage up to 80% damage. So how many of us really do the categorizing the disease so that we have the target pressure set up, and how important it is? RK sir, Dr. Krishnadas, and all the other panel members can join in.
I would just like to add one, sorry, sir.
It's a good question, but simply just with one parameter, we cannot categorize the glaucoma as a mild, moderate, or severe. It's a combination of everything. It's a combination of, as you mentioned, a careful assessment of the optic nerve head is very, very important. Number one. Number two, of course, is the visual fields, which are to have a very good, effective treatment, scientific approach to treatment of a glaucoma. A visual field, baseline visual field is very, very important. Number two. Number three is, of course, intraocular pressure and CCT. All these three factors are important when you planning to start treatment and also categorize the glaucoma. And of course, this is very important. It's not mild, moderate, severe because how much you have to, what are the anti-glaucoma medications you have to do, whether you start with prostaglandin or just a simple beta blocker is sufficient to control the intraocular pressure. Or we have to add some other drugs or start primary treatment with prostaglandin. All these things are very important. All depends upon how much damage the patient is having and what's the field defect and all this. Because unnecessary, because we are seeing patients are loaded with anti-glaucoma drugs, even for
Yes, sir.
glaucoma.
Yes, exactly. That is the reason why I was just asking this question.
So,
Because the moment you see 0.9 or 0.8 CDR, we think the patient has too much of a damage. But unless we see the visual fields and the OCT, the damage, especially the GCL pattern, we may be really over treating the patients.
Yes,
so it is
diagnosis, especially with this OCT and visual fields, even with a few red spot or a black spot, over diagnosing glaucoma is very, very high. So in that case also, because we have to see whether the patient is having a definite glaucoma or not. That's very, very important. Suppose if you have a doubt, there is nothing wrong in waiting for the treatment. So that's very, very important. But otherwise, you are unnecessarily making a patient, a asymptomatic patient, into a symptomatic patient. Because most of the early glaucoma patients are early, moderate or asymptomatic. They won't have any symptom at all. They will be doing their regular activities and regular everything. We are telling them that you are having glaucoma. So
yes, sir. Yes, sir.
Yeah.
Both the empathy and the sympathy the patient really requires.
We should not make them symptomatic. That's a thing. Make sure the patient is definitely need glaucoma treatment or not. If it is necessary, what drug should be given? Since the drugs are new or since the drugs are expensive or since the patient is very rich, we should not treat. We should not alter we should not change the treatment protocol. That's what I feel.
Anything else, Dr. Krishnadas or Rangaraj? Dr. Rangaraj and Dr. Mohan, sir?
Satyan, I have got two questions, Satyan.
Yes.
Yes, sir. Please, sir.
The panelists, we have seen a perfectly normal, apparently normal disc, but the OCT RNFL showing consistently red. Okay.
Yes,
What's the reason for that? Number one. Number two question is, how do you manage normal tension? We see many patients having only 17, 18, but normal tension glaucoma. How do you manage that? And third question, I will just finish off. The third question is that I have a couple of patients, whatever anti-glaucoma drops you give, the cornea, the epitheliopathy is there, ocular surface disease. He is not able to tolerate any drug. So what do you do for such patients?
Sir, for question number one, that is your RNFL showing the red pattern. One is always look at how the OCT is being taken, because one obviously is the segmentation issues that we have. How good is the quality the OCT has been taken and how the segmentation has been done. That is a part one. Second part is the RNFL changes, as I mentioned earlier, it need not be only the glaucomatous changes. It could be so many other things, including myopia. So once you have ruled out and you still feel that it is a RNFL damage, that really helps us to see whether the patient, the changes are more closer to the papillomacular bundle. If it is so, then it signifies the patient has more of a normal tension glaucoma pattern or the open angle glaucoma with a vascular compromise. That is one of the signs that we will have to pick it up. So once you pick it up, say, for example, you have the pattern of normal tension glaucoma, then obviously we need to see there are two patterns. One is the fast progressors in normal tension glaucoma versus the stable, more or less very, very slow or stable disease in the normal tension glaucoma. Those with the vascular compromise, most of them may have a carotid vascular disease or a cardiovascular disease, or they may have a sleep apnea problems. Once we have identified this, then possibly we can treat. Or the other things which we may have to consider is whether the so-called NTGs, whether the patients having an angle closure disease or the sirasasanas which they are doing, the exercise patterns. Once we have a good detailed history, one by one we can roll out and make sure that the patient becomes more or less stable. Many of the patients I have seen that once they've undergone the cardiothoracic surgeries or carotid vessel disease treatment, they do have either a stable disease.
Yeah.
Is carotid Doppler a must for these patients? NTG patients? Krishnadas? Satyan?
I think both carotid studies and neuroimaging.
They will never show any
is a
improvement, at
must.
least they will have a more or less a stable disease.
Yeah.
Yes, sir. Especially if we done one-sided more neuroimaging is a must. So these patients can be definitely picked up and treated better, sir. The third part to answer once you feel that the patient has more or many ocular side effects, or the patient is not tolerating the medications, one option you have is going in for an SLT at the early stages of the disease. If you, provided that you do a proper gonioscopy and you shoot with the proper power settings. But many of the people think the pigmented Swalby's line as trabecular meshwork and that they do the SLT, it is never going to work. So once it is a proper trabecular meshwork that you have treated, definitely the SLT works in a treatment-naive patients than the patient who are having already on 2 or 3 medications. Probably these patients, you can reduce the number of medications, but you cannot completely take off the medications for these patients. So once you feel that the ocular surface disorders are more, trabeculectomy is going to be one of the best choices that you can have. It is not that the good phaco surgeon cannot do a good trabeculectomy. It is just the training that we really require. So that can be definitely done. And just to having a small promotion here on the TNYA conference, we have the wet lab. We can probably train more number of people in doing the trabeculectomy in 10 minutes or 15 minutes time. So it's not a big thing. RK sir is there, Dr. Krishnadas, and so many other good glaucoma persons are there. We can definitely train more number of glaucoma persons. At least I just take this opportunity in this podium to welcome more people for this TNYA conference for the wet lab, so we can train more and more people in doing the trabeculectomy. So over to you, Mohan sir and other panelists. And at the last, I will just request, give me 1 minute time for talking about the TNYA conference.
You already talked now, Satyan.
Yeah, just to say that
you can talk about the TNOA conference and also give the vote of thanks. Yeah, TNOA conference and vote of thanks.
Yeah, this is the TNYA conference is on August 5th, 6th, and 7th at Coimbatore, Codicia Trade Hall. We welcome you all here at Coimbatore. At the time that it will be a very pleasant weather. And the Codicia Hall, I think many of you must have seen, it is one of the wonderful places to visit. And abstracts are already open. The registration is already open. Till April 10th is the abstract submission. IC submissions are also coming now. Please do submit as many number of abstracts as possible. So we'll have a great conference. We have a conference with a difference here. We're all waiting to receive you here.
Super. Thank you.
Yes, Satyan, it's very important because the outgoing president is handing over to the incoming president, Dr. Mohan Rajan. He belongs to my alma mater in school.
Thank you.
Of course, Dr. Ramkrishnan, my mentor. So I think I am very, very personally interested. So I am, on behalf of all of them, I am inviting everybody to the TNA conference this year.
That's wonderful. Thank you so much. Though we say always, we say a respected president to address, but I would like to say we have 2 dearest presidents here. President already there, and the incoming president, the dearest our incoming president also. So thank you all once again for the great opportunity given to us today. So welcome you all for the forthcoming TNYA conference. Thank you all.
Thank you. Thank you.
I would like
Dr.
to
Mohan.
sincerely thank.
I'm
so sorry.
I would like to thank. I would like to thank Aravind Eye Hospital, Madurai, Krishnadas, and the entire team for connecting this webinar, and it's really fantastic to have all of you, and also Hoya Surgicals for Surgical Optics for sponsoring this, powering this webinar, and of course our I would call them what do you call the superstars, the Numerotech. They are always behind us, the back end work and doing this without any flaw. This is really fantastic. Looking forward to more the talk with Dr. Madhivanan Natarajan, the giant of ophthalmology, as far as Tamil Nadu is concerned, on April 2nd at 8 p.m. IST. That is Saturday, coming Saturday, with Madhivanan Natarajan. The Walk the Talk series has become very, very popular because we learn from this luminaries, the legends of ophthalmology, and get inspired, rejuvenated, and get motivated as well. Looking forward, stay tuned. See you guys soon.
Okay. Okay, bye.
Bye.
So thank you, sir.
Thank you.
And
Thank
once
you.
again, I would like to thank